Sharan Sundaram from US. And today we are fortunate to have Professor Jeremy Chapman with us, and who will be enlightening us about the various aspects of post-kidney transplantation. So with this, I conclude my presentation. Now I would like to invite Professor Vivek Kute. He does not need an introduction. He's a professor in nephrology and transplantation division of IKDRC. Ahmedabad. Sir, please.
Welcome, Professor Jeremy Chapman, all the national faculty and delegates for joining us this hybrid event, Transplant Conclave. India is number 3 in the world for absolute transplant numbers, only USA and China. As per 2022 data, India has crossed more than 15,000 organ transplants in 2022. Kidney is commonly transplanted organ around 65 to 70%. Liver contributes 25%, and other organs contribute to less than 5 to 10% of the transplants. Around 85% transplants in India are living donor, and less than 15% are deceased donor, which is active mainly in the South and West India. So government is giving priority to expand deceased donor organ transplantation in 2023. Last month, Honorable Prime Minister Shri Narendra Modi ji has highlighted the need and awareness about deceased donor organ transplant in his 99th Mann Ki Baat on organ donation. So we, as the Indian Society of Organ Transplantation and largest transplant institute, we continued our efforts to increase access to organ transplantation in India. Around 1/3 of the living donors, they are rejected because of ABO or HLA incompatibility. There is a logistical challenges for the swab transplant in India. So many centers prefer ABO incompatible transplant, which is medically complex but bureaucratically simple. So we have the first session on ABO incompatible transplant, how we can improve the long-term outcome. This session will be moderated by Dr. Vishal, Director of the Max Hospital, Gurgaon. I request Dr. Vishal to start this session.
Good evening, ladies and gentlemen. At the outset, I would like to thank Intas Pharmaceutical, and I would like to welcome Professor Jeremy Chapman for giving us a time and a time to interact with you. And thanks to Dr. Kute. So our first session will be ABO incompatible transplant, how to optimize the outcomes. And we'll start with the speaker, and after that, we'll have the panel discussion on that. So we have Dr. D.S. Ray, who's the Senior Consultant and Chief of Renal Transplant at Rabindranath Tagore Hospital, Calcutta. So he'll be talking about ABO incompatible transplant, how to optimize the outcomes. So he'll be speaking online, and after that, we'll have questions. So we go ahead with our first session today. Dr. D.S. Ray.
Thank you. Thank you, Dr. Vishal. And thank you, Intas and the people organizing the seminar for inviting me. I apologize because I'm not able to be present there physically, but I'll compensate by speaking virtually. Let me share my slides.
Dr. D. Sir, can you hear us?
Yeah, I'm there. There is some problem in sharing.
PPT from this.
Hello.
If there is a technical issue, can we share your presentation from here?
I have, yeah, okay, fine. I have sent the PPTs, so one can start that.
Okay. Yes,
It's not visible.
sir. Can you see the presentation, sir? Dr.
No, no, no. Can I try sharing again? It's not coming. Yeah, it is visible now. Is it okay? Is it visible properly there?
Yes, sir. Can you see?
Yeah, I can see.
Can you see the PPT?
Yeah, I can see the PPT. Yes.
Okay,
So
please start.
do I go ahead? Hello.
1 minute, sir. We are coming to the first slide. Please start, sir. Dr. Ray, can you hear us?
Yeah, I can, but these slides are. You go to the second slide. I mean, I can't operate from here, I believe. Next
Okay,
slide,
you can
please.
just say next slide.
Next,
It
please.
will change. Okay, sir. Please start.
Okay. So, what we'll discuss of different outcomes of ABO incompatible kidney transplant. We'll discuss about graft survival, patient survival, rejection episodes, incidence of infection, and of course, in India, any transplant discussion will not be complete without the cost discussion. So we'll go one by one. Next one, please. Next slide, please. So for desensitization, one need to remove the circulating ABO antibodies. So there are various methods by various hospitals or institutes do use. Plasmapheresis, double filtration plasmapheresis, immunoadsorption. The choice of technique will be related to the availability of the technique, the cost of the technique, and the comfort with the technique by the institute. Next one, please. Next, please. Okay, it will also include cell depletion. Earlier days, it was being done by splenectomy. Presently, we do use rituximab, which is a great boon to us. And then maintenance immunosuppression, similar to ABO compatible transplants like CNIs, antimetabolites, and low dose steroids. Next one, please. These are some important preconditioning protocols by different well-known institutes. The first one is from Tanabe's Tokyo Women's Universities. He uses rituximab in a dose of 200 milligram per meter square. He does DFPP and starts methylprednisolone, tacrolimus mycophenolate from 10 days minus day of transplantation and gives 2 doses of basiliximab and does the transplantation. The John Hopkins, it's their protocol which is available, but after 2019, the daclizumab is no more available. So the older protocol shows they use plasma exchanges and they use IVIG and they use a rituximab of 150 milligram per square meter of body surface, and they give 4 doses of daclizumab and continue plasma exchanges and IVIG post-transplant too. Next. Okay, the Freiburg University of German does a good number of ABO-incompatible transplants. They use a higher dose of rituximab, 375 milligram per square meter, a month prior to transplantation. They use triple immunosuppression, which starts 10 days prior to the transplantation. They use single dose IVIG 0.5 gram per kg pre-transplant, and they do immunoadsorption pre-transplant, and they use basiliximab as induction therapy. And post-transplant, the immunoadsorption is used if required. Mayo Clinic does plasma exchanges. Mostly USA centers do plasma exchanges. European centers do have access to immunoadsorption. So Mayo Clinic uses plasma exchanges, and the replacement fluid is albumin and FFP. They use ATG 1.5 gram per kg as induction therapy for 5 to 7 days, relatively longer than what we use in India. And post-transplant plasma exchange and IVIG are also given on day 1, day 3. Next. Coming to the graft function, the earlier days data, the older era when the rituximab was not available and when the tacrolimus and mycophenolate were not available with methylpred, cyclosporin, azathioprine, ALG, and deoxyspiritualin, which is used to be more used in Japan. The graft survival has been poor, around 78%, and rejection had been 48%, as high as 48%, which has significantly dropped 2000 to 2004 era when they had done splenectomy, but the tacrolimus and MMF were available. The graft survival at 1 year was 94 and the rejection rate was 15%. Next. This the first one is the graft function in different eras, 89 to 94. It's from Japan. 95 to 2000 and 2001 to 2006 with the advent of rituximab, there has been significant improvement in the graft survival at 5 years. Similarly, other authors have also shown better survival than the earlier days. Next. Then there are multiple studies from Japan, from Yunus, Montgomery from US, where they have shown up to 9 year equal graft survival as it is in the biocompatible ones. So there has been no difference in the graft survival. Next. Even there are certain studies like mostly Japan and Germany and Baltimore also, where the graft survival, even though statistically not significant in abio-incompatible transplant, has been shown to be better than the abio-compatible ones. Next. Next. This shows the patient survival, which have been all throughout the ages, been similar to the abio-compatible ones. At 1 year, 3 year, 5 years, 7 year, 9 years, the abio-incompatible and abio-compatible patient survival have been similar. Next. There was study in 2011 where it showed the rituximab causes more of viral infection like herpes simplex, varicella zoster, polyoma virus because of use of in abio-incompatible recipients. There was a paper from France in 2011 to 15 where they showed the overall infection rate to be higher in abio-incompatible transplants. So also the BK viremia was shown to be higher than in the abio-compatible transplants. Next. This is a study from USA, from 2000 to 2007, where they showed initial month the complications with abio-incompatible transplant were higher. The bleeding, I'll tell you later on how we can control the bleeding during surgery, the infections, etc. which after 90 days, after 3 months of transplantation, has been almost equal to the abiocompatible one. But study from Sweden doesn't agree to that. They showed the infection rate to be similar in both the groups. Next. This is an interesting study which was published in CJSN in 2018, where they have chosen 26 centers, mostly from Europe and USA, and they have shown the infection rate to be higher in majority of the studies. Some of the studies showed it to be similar, and they concluded the abio-incompatible transplant is a good way of doing the transplant because people don't do well on dialysis. However, the infection rates and transplant graft survival is inferior to abio-compatible ones. Next. The infections which are prevalent could be wound infections because of bleeding, because of diabetic patients, because of use of mTOR inhibitors, urinary tract infection because of rituximab, viral infection again because of rituximab, the CMVs, the BKVs. Next. The increased infection is attributed to the additional immunosuppressants like rituximab and plasmapheresis. Plasma exchanges cause hypogammaglobulinemia, reduced by 60% even with one single plasma exchange. Rituximab similarly increased the risk of pneumocystis pneumonia, CMV, fungal infection, interstitial lung disease, and very, very rarely progressive multifocal leukoencephalopathies. Dr. Tanabe in his study has shown 30% patients with abio-incompatible transplantation can have neutropenia post-transplant. Next. Next one, please. Now I'll come to our institute studies where how we have modified our protocol to get a better result, to get a lesser rate of infection and better graft and patient survival. We have started transplantation, abio-incompatible transplantation in 2013, and roughly we do around 30 transplants in a year, except for that 2020 in the COVID year. Next. This is our protocol, which has been published. You can get it in the journals. We give rituximab 100 milligram if the antibody titer is 512 or less, and we give 200 milligram if it is more than 512. And we also simultaneously start steroids, tacrolimus 0.1 milligram per kg body weight, keeping the T0 level 9 to 12 and mycophenol at 1.5 gram per day. We admit the patient 7 days prior to the transplantation, start plasma exchanges and give IVIG on alternate day by 5 gram of IVIG. We give 2 doses of ATG on the day of surgery as well as the next day for 1.5 milligram per kg body weight per day. And we do the transplant once the target antibody titer is 1:64. Next, please. We have, over the period, we have tailored our preconditioning. Initially, when we started, our target antibody titer was kept as 1:8. Then it was increased to 1:32, and presently we are happy with 1:64. The initial prednisolone dose was started at 50 milligram per day, and maintenance was 7.5 milligram. But presently, like abio-compatible patients, we give 20 milligram per day initially and come down to 5 milligram per day as a maintenance dose. We have been, if the antibody titer is 1:32, we may do one plasma exchange or we may not do plasma exchange. We just give rituximab and do the transplant. Similarly, if it is 1:116 or less, we straight away do the transplant after giving a single dose of 100 milligram of rituximab. Antibody titer are monitored only when required. We don't do a regular monitoring because it doesn't have any value. And we do not do any prophylactic plasmapheresis post-transplantation. Next one, please. Next one, please. Am I audible? Am I audible? Can you put the next slide, please? Hello. नेक्स्ट स्लाइड. हाँ, स्लाइड नहीं दिख रहा है. Okay. Okay, it's visible. Just go ahead. Okay, I can do it from here now. Is it visible there? Hello.
Yeah, continue, Dr. Ray. Please continue.
Yeah. The rituximab we started in 2013 to 14 at 500 milligram per body. We decreased it to 200 milligram. Then after a study of ours, we have decreased it to 100 milligram per body if the antibody titer is 512 or less. And if it is more, we give 200 milligram of rituximab. Similarly, antibody depletion we do by conventional plasmapheresis because it is available in all institutes and it is cheap. So we exchange a volume of 30 ml per kg, and the replacement fluid we use is FFP because albumin is more expensive. This is our first paper which was published in 2016, where we had shown good result with 45 patients of ours. Then we did a study of prospective study of ABO incompatible and ABO compatible transplants in a shorter period, 1 year follow-up. The all patients who were transplanted between 2014 to 2015 were taken, and in each group we had 30 transplant patients in the ABO compatible and incompatible. There was only one ABMR, HLA related ABMR in the ABO incompatible group, which was successfully treated. In both the groups, there was one death each. In the ABO incompatible group, it was because of the Acinetobacter. In the compatible group, it was because of the Acinetobacter infection, and in the incompatible group because of the aspergillosis. The average creatinine, the average GFR, the graft rejection rate, the post-transplant hospital stay, the infections were all statistically similar. This article of ours were published in SJKDT. We also, there is a fear with amongst the nephrologists not to do transplantation if the antibody titer is very high. Maybe if it is 512 or more than that. So we compared two groups. We took two groups, one with the 256 antibody titer or less, one with more than 256, and we followed them up for 1 year in each group. And we found that there is observational study, it's a comparative observational study, which concluded that whatever might be the baseline antibody titer, they can be desensitized adequately to ensure transplantation. Moreover, there was no significant difference in the outcome of both the groups, whether it is a low antibody, initial antibody titer or high antibody titer. We also did a long-term follow-up of the patients from 2015 to 2018. 75 ABO incompatible transplant were compared with the 75 ABO compatible transplant done at the same time. And the mean period of follow-up was around 5 years. We have done antibody, initial antibody of in this group up to 1,400, up to 4,096. And if you see some of the patients we have transplanted with an antibody of 64 even. The highest antibody titer we have transplanted has been reported, and this is the highest probably reported in international journal. Nobody has reported higher to this. The titer was 8,196 or more than that, because our laboratory can maximum estimate up to 8,000. So it could have been 16 or 32 or even 64,000. But we could successfully do the transplant. So initial antibody titers should not be a contraindication for doing a bioincompatible transplant. Coming back to the long-term follow-up, the duration of admission was 20 days because some of the days we admit for the plasma exchange and IVIG treatment. The biocompatible and incompatible, the graft function has been equal. The death rate has been statistically, there has been no difference in the bioincompatible. 5-year survival was 90.7% and 5-year in biocompatible one was 93.3%. The rejection rates were similar in both the groups. Infections were more or less similar. It is slightly more in the bioincompatible group, but statistically not significantly different. So how do we reduce the infective complication? We reduce by reducing the dose of rituximab. Publications of our taking 52 patients into account between 2016 to 19. We gave both 100 milligram and 200 milligram of rituximab, and we found both are equally effective. We count CD20 from day 0 to 1 year, and they both are similar in both the groups. Only there was a lower infection rate when the rituximab dose was low. So we have minimized our rituximab dose. We also lowered the dose of anti-proliferative agents. We use 1.5 gram of mycophenolate, and which is reduced to 1 gram after 6 months. We limited the number of plasma exchange by increasing the pre-transplant titer to 1:64. And like biocompatible ones, we give long-term prophylaxis of cotrimoxazole and valganciclovir. The paper of our comparative study between 100 and 100 milligram rituximab and 200 milligram rituximab has been published in the Transplant Proceedings. We also do number of patients where both HLA antibodies and ABO antibodies are there. HLA antibodies are difficult to desensitize. This is an interesting case which we reported where we did the third transplant. Mother was the donor, and there was both ABO, the blood group was different. There was both ABO incompatible, ABO antibodies, HLH, HLA antibody. We successfully desensitized, and she had been transplanted, a young girl. Now, after 5 years of transplant, she has got married and she has recently had a child. No discussion of transplant will be complete without discussing the cost, especially for Eastern India, where our people are not as rich as Northern or Western India. There are very few papers on transplant cost. One of them comes from USA, where they have shown the ABO incompatible transplant cost is double at the time of transplantation. It is also as high as around double in the first year, second year, and third year. There is another paper from Japan by Professor Tanabe. In fact, I reviewed this article in clinical transplantation, where the cost of transplantation was high during the transplantation, but it was similar in first and second year, and the cumulative cost of transplantation in 3 years were similar in both the group, ABO compatible and ABO incompatible. We have reduced the cost by using low dose rituximab, using plasma exchanges 30 ml per kg, not DFPP or immunoadsorption. We use FFP because it is cheaper than albumin. Also, if you use FFP, there is less chance of bleeding during the surgery. And we use low dose IVIG. It helps in reducing infection besides modulating the immunosuppression. We have increased our target antibody titer to 1:64. We don't do post-transplant monitoring of titer unless clinically required. We don't do post-transplant plasma exchange unless it is demanded or unless it is required by the patient. And we change MMF to 1 gram after 6 months. But if the patient can't afford it, we switch over to azathioprine, which is much cheaper. With this, our cost is a plasma filter will cost something like 8,000 rupees. FFP per unit is around 500. We'll need around 8 FFPs, so around 4,000 rupees per plasmapheresis. IVIG 5 gram will cost 12,500. Rituximab 100 milligram will cost around 4,500. Plasma filtration procedure is around 1,500. So expenses with 5 sessions of plasma exchange will be around 1 lakh rupees or $1,450 US dollars. And if we do 10, then it will be around 2 lakh rupees, which is not high. So concluding, ABO incompatible renal transplantation with plasmapheresis, low single dose rituximab, low dose IVIG in combination with standard triple immunosuppression can be performed with excellent results. Results are comparable with ABO compatible transplants, only moderate escalation of cost, no additional infrastructure required, and it can expand the donor pool from the family by 30 to 35% as shown in a study from CNC Baylor. Thank you for a patient hearing. Sorry for the disturbance in between.
So I start with Dr. Manish Jain. So Dr. Manish, as I said, is there any difference in long-term graft outcomes in ABO compatible versus ABO incompatible transplantation?
ABO incompatible transplants have got a lower graft and patient survival as compared to the ABO compatible transplants. And if you see in the long term, the survival is almost safe. So there was a meta-analysis of, I think, in 2019, which had 40 studies, which showed that patient survival mortality at first year, third year, and fifth year was more in ABO incompatible, while the doctor said that survival was it was comparable after 5 years. First and 3 years, it was more in the ABO.
So you mean to say that the first 3 years are more crucial as far as the comparable between the ABO incompatible versus compatible is concerned? Thank you very much. The next question is for Dr. Vijay Sinha. So how do you see the role of post-transplant apheresis? And what would be your indication for doing an apheresis if ever you have to do?
So at our center, we are not routinely performing any post-transplant apheresis, and that is perhaps the case with most of the publications of most of the journals that state no post-transplant apheresis is required unless there is an absolute rise of the titer along with some clinical deterioration of the renal function or maybe some evidence of TMA that is mostly happening with the post-transplant in ABO transplants. Unless and until there are certain compelling indications, we are not doing any apheresis.
All right. My next question goes to Dr. Ashish Nandwani. Dr. Ashish, do you see a role of any protocol biopsies in ABO incompatible transplant?
So I think the role of protocol biopsy remains the same, whether it is ABO incompatible or incompatible transplant. So these are usually done in the research or a part of some studies, but routinely we are not using it. And the studies have also shown that the chances of getting these findings of rejection in the absence of any clinical evidence of deterioration of renal function is usually not there. So the studies have shown that you might get some subclinical rejections, which is again compatible in both ABO incompatible or compatible transplants. So if the patient is having some features of graft thinking of rejection, either antibody mediated or cellular rejection, then I think indication biopsies are there. So in the present era, protocol biopsy, and the other thing is patients are usually unwilling. If they are doing well and you tell them to undergo protocol biopsy in our settings, they usually don't prefer. So that is the thing.
All right. Next question to Dr. Cabra. Dr. Cabra, what do you think is the utility and role of IVIG in ABO incompatible kidney transplants?
So, Dr. Vishal, there is a lot of variability we see when we discuss the protocols among the centers.
Exactly.
Many of the centers, in fact, I understand, do not use IVIG. However, it depends upon, in my practice, it depends upon the pre-transplant immunoconditioning which you have done, how you have done that. If you used plasma exchanges, and a lot of plasma exchanges, maybe more than 3, there might be some role of IVIG because you have washed away a lot of immunoglobulins and risk of infection, especially pneumococcal infections, etc., remains. However, the flip side is that whenever you give IVIG, you're also, it's a non-specific type of IVIG, and you're supplementing immunoglobulin D for anti-A and anti-B antibody. So in our practice, we use immunoadsorption columns, and we usually don't.
Because it comes from the various pooled sera. Body titers. I mean, what would be your take on how high is how high?
So that was the question I was going to ask. Because the issue is out of your control. It's in the laboratory, and it's in the laboratory's quality assurance program, and it's in the particular technique that they use. And so the problem is that we each have to learn it with our own hematology laboratory. I can give you an anecdote for us. We and Royal Prince Alfred Hospital did ABO incompatible transplants at about the same time in Sydney. And the results that we got were always extremely high. And we would look at the transplant and say, no, we're not going to start with 1 in 256. Because 1 in 256 at Royal Prince Alfred meant that they were unable to desensitize them. Right. And it wasn't until I started sending blood to both laboratories that I realized there was a 4-fold dilutional difference between the 2 laboratories. So when we were getting 1 in 256, it was more like 1 in 16 in LA. And so I think that's the clearest message I would give to everyone in India. You have to learn it with your own laboratory. Perhaps you can send bloods, a representative number of bloods, to another experienced program, like Calcutta, as we've just heard, and say, okay, what was the titer of this blood in your lab? Because otherwise you're not going to get the answer to your question, because your lab is going to be different to every other lab. And of course, then you need to keep an eye on your lab, because they'll change the assay on you, because they weren't doing it for that reason, they were doing it for themselves. And so the answer to the titer is you have to learn it yourself. And the difficult thing is to learn it the hard way with patient results. So I would strongly advocate a good relationship with your laboratory, a stable test that they can validate and revalidate with time, and can then compare people's titers. So I will never take a number of a presentation like this and translate it back into our unit, because I know we're not using the same hematology lab.
Thank you very much. So again, as we can see that inter-laboratory variations, the methodology of using which method you are using, whether you're using a tube method or a column agglutination, it depends, and your titers will change accordingly. So I think with that, we bring out to the end of this session. Thank you very much to all the panelists. Special thanks to Dr. D.S. Ray for giving a very nice presentation. Thank you very much.
Thank you.
Professor Chapman, can you join us for photograph?
Thank you very much.
Thank you all the faculty. Moving on to the next session, that is role of rituximab in nephrology and transplant. I invite moderator Dr. Manoj Gumbar sir, transplant physician at Apollo Hospital, Ahmedabad, and sir is also mentor for me over the last 15 years. Over to Dr. Manoj Gumbar.
Good evening, everybody. Now, this next session is use of rituximab in nephrology. The session is on use of rituximab in nephrology. And for this, may I invite the panelists, that is Dr. Rajesh Jorawat from Jodhpur, Dr. Manish Kumar Jain from Kolkata, Dr. Javed Vakil from Ahmedabad, Dr. Tanmay Pandya from Faridabad, and Dr. Jagdeep Shah from Ahmedabad. And the speaker for this use of rituximab in nephrology is Dr. Shishir Gang. We've already discussed about the use of rituximab in ABO incompatible, and maybe the next following session will be on rejection. So I'll request Dr. Gang to just discuss on use of rituximab in nephrology, in nephrotic syndrome and vasculitis in detail. Thank you, sir. Please come over, sir.
Thank you, Dr. Manoj, for the kind words. And I'd also like to echo the sentiments expressed by the earlier speaker and thank Dr. Kute and Intas for getting us all together. And it's really a privilege to be here. And also thank Dr. Jeremy for traveling all the way from Australia to be with us today evening. The task given to me was to talk about rituximab nephrology, and as has been already alluded to, it's a very vast subject. So I'll restrict myself to certain aspects of glomerular disease. As we all understand that the B cell are the crucial cells which produce antibodies, and we have a lot of problems with antibodies. So naturally, if we can get rid of those B cells, it will be the best thing to do. They express CD19 and CD20, except for the plasma cell, which does not express the CD19, and CD20 is not expressed in the plasma blast also. So they engineered that there is a molecule known as CD20 on it, and if you use an antibody to it, you could probably kill this cell. What is the real function of CD20 is not absolutely clear, but it is something to do with some calcium channel to the survival of the B cell. So if you interfere with CD20 expression on the B cell, it usually leads to death of this cell. Now, as you can all understand, what is the mechanism of it? Because a bit of pharmacology, I would just prelude to the talk that I give about the role in other diseases, is that this molecule can act either by complement activation and kill the cell. It can also activate the natural killer cell and the cell can die, the B cell can die, and also can cause antibody-dependent cellular cytotoxicity. Important to note is that the B cells are not only the cells which produce antibodies, but they are also an antigen-presenting cells. They can take in the antigen along to the antibody, process it, and then presenting it to T cells. So therefore, we see that many disorders where there is a predominant T cell known, but even in those disorders, B cells or anti-B cell therapy seems to be working equally good because there's a lot of overlap between the B and the T cell work and the pharmacology. What are the usual side effects that you usually associate with the infusion of this rituximab is fever, chills, tachycardia, hypotension, arthralgia. However, important note is because it is a B cell suppressant, it can also lead to infection, especially some of the serious infections that happen with it, can lead to long-term or late onset neutropenia. This is very important. So sometimes patients who have been on rituximab later on when you use antiproliferative therapy may not be able to use them so well. And of course, it can cause A-gamma globulinemia and can also increase the risk of infections. So as alluded to by the moderator, I'm going to speak only about the role in the primary vasculitis, membranous nephropathy, and something about FSGS and minimal chain disease. Will not speak on the other immune disorders, and also will not speak about its role in ABO and computer desensitization or prevention of rejection or post-transplant lymphoma or post-transplant nephrotic syndrome. As you all understand that in ANCA-associated vasculitis, its pathogenesis is not absolutely understood, but it is believed that the ANCA are an important cause for the vasculitis. And these ANCA antibodies are produced by the B cells. They attach to the neutrophils get activated and then cause all the damage. So if you can reduce the B cells, and probably the neutrophil activation will not be so, and hence you'll have a salutary effect on the prevention and treatment of this disease. So a number of trials were done on these things, and there were two trials, which are the most landmark trials, the rituximab and the RAVE trial, which was done as an induction therapy for using rituximab. And then there was a maintenance trials with the 4 trials. It is the main-rituxan 2, rituximab, and main-rituxan 3. So let's go through some of this and see what they did and how we can change our practices currently. So trials for the induction therapy, the first one was the rituximab trial, which they had 3:1 randomization of patients to newly diagnosed patients to either using rituximab, 300 milligram per meter square body surface area, and also they were given 2 doses of IV cyclophosphamide. And in the control group, that was they were using IV cyclophosphamide followed by azathioprine. And if you can see that the endpoints were no different either in terms of the outcomes as well as the side effects, and also the improvement in the GFR, which happened over a period of time. So it did show that rituximab showed that the rituximab can be used along with cyclophosphamide when they use 2 doses, that it is an the maintenance therapy, that is the rituximab. One was a fixed dose, as we saw in the previous slide. Another was depending upon the CD19 counts and NCA. Obviously, but if you used it based on the titers of CD19 and NCA, the number of injections that you need to give is lower. And essentially, there was not much difference between the relapse rate. So you could use a tailored therapy in the maintenance therapy also. Then the third trial, which came after, of course, how long to give the therapy, because as we all understand, you give it for 2 years, and then what happens? I do continue with the maintenance therapy or stop the maintenance therapy. So what I did was the patients in Ritsan who were in remission, and 28 weeks onwards, they continue with the rituximab infusions every 6 months. And another group, they had a placebo group. So if you continue for up to almost 4 years, what happens is that you get, if you continue rituximab later on also, you get almost 100% relapse-free survival. However, if you do not give that, then you will see about 13% patients will have relapses over there. And adverse events were no different whether you continue to give rituximab or not. So it essentially showed that all these trials have shown that in ANCA vasculitis, because it is a relapsing disease, you need to continue with the maintenance therapy. And probably, at least in these trials, they have shown that rituximab, if you can be given it safely over a long period of time. Then essentially it came down to that, of course, the azathioprine is a cheap and effective and well-known therapy for maintenance. So there's another trial where they use especially relapse. So they gave also as 1 gram, 4 months they gave 1 gram over 5 doses. Compare that with this and they showed that if you use rituximab compared to 38% if you use azathioprine, again showing that rituximab is superior in preventing disease relapse. So again, there was a meta-analysis of many of these trials and comprehensive. It showed that if you use rituximab compared to azathioprine, methotrexate, and MMF, they have a relapse survival which is much better, and also the risk of relapses are much lower compared to that. What about the KDIGO, which has come out in the 2021 about the guidelines for use of it? So if you have a patient who has got diagnosed vasculitis, you can either go with cyclophosphamide and corticosteroid, or you can go with rituximab with corticosteroid. If they go into remissions, then they need to go into the maintenance therapy. Either you can use azathioprine, rituximab on demand, or rituximab is in a fixed dose method. If it is a very rapidly progressive, very high creatinine or crescentic, then one may consider a pulmonary hemorrhage, one may consider add plex. Again, it has been shown that patients who have very severe disease, cyclophosphamide will be slightly superior. So how do you choose the therapy in induction? So generally, there are children, adolescents, rituximab is preferred. In premenopausal women concerned about the fertility, and even in men, if there's concern about fertility, then rituximab is preferred. Frail and older patients, it will be preferred. Glucocorticoid sparing agents and PR3 ANCA disease, rituximab may be preferred because it is more likely to relapse, and therefore you may use that. However, cyclophosphamide is actually quicker to act and faster to act. It is cheap. And in severe cases, there is still people who believe that using cyclophosphamide combined with rituximab may give a better outcome compared to using either therapy alone. In the maintenance therapy, again, if you've got a relapsing disease, then rituximab is preferred. Again, PR3 ANCA, it is preferred. Elderly people, it is preferred. And glucocorticoid sparing effect is much more with rituximab compared to that with azathioprine. But in patients who have a very low IgG levels, then azathioprine may be better because, as you know, rituximab depletes the IgG levels. Again, with patients with hepatitis B, again, it has been shown that patients with hepatitis B, the risk of flare-up of hepatitis B is much higher with rituximab, and therefore we may consider using azathioprine. And of course, cost and the availability remains an important issue, especially in our country. But with the reducing cost, we believe that this may be more widely available and used. So this is about the ANCA vasculitis and current status of how to use rituximab in ANCA vasculitis. Now, moving to membranous nephropathy, this is another disease where rituximab has been extensively studied. So essentially, membranous nephropathy has been that you need to classify membranous nephropathy because all membranous nephropathy is not similar. And you should know which patients are likely to progress. Depending upon the progression likely, you can choose your therapies. So low risk is one which has got less than 3.5 gram proteinuria and a serum albumin more than 3 grams. And patients with moderate risk is more than 4 gram. And patients who have a low titer of plateau R, and there is a low amount of low molecular proteinuria, they are more selective proteinuria. And as it go higher, you've got a decrease in the GFR, higher proteinuria, higher titers, low molecular protein. Low molecular protein essentially tells you that there's a lot of tubular damage existing. Again, increase non-specific proteinuria again tells you that more damage to tubules have been happening also. and very high is, of course, a very rapid deterioration. So based on that, of course, membranous nephropathy has been studied for many, many years. Over last about 7 decades, it's being studied. And the landmark studies have been that of Ponticelli, who really established that the role of alkylating agent with steroid would become the gold standard for treatment. When rituximab came in sometime around 2010 onwards, there were trials. And once the PLA2R antibody was recognized to be an important cause of membranous nephropathy, the interest in rituximab as a therapy for membranous nephropathy has started. And there are 4 essential landmark trials, which we shall see what they have done and what they teach us and how we can take our practice further. So essentially, the first trial was a GEM-RITUX trial, which actually compared rituximab with no immunosuppressive agent. So they only used RASI therapy, that is RAS inhibitors in this situation. So what they did essentially was that this is a trial which has been done in France, and they used rituximab compared with the only RASI therapy, and they showed that at 3 months and 6 months, there was a significant reduction in the PLA2R antibody. Also, patients going into complete and partial remission, which about 35% and 21% as shown with only if you use only this. And this established that rituximab has an impact on the proteinuria as well as on the remission at 6 months. And also the PLA2R antibodies come down much faster with rituximab compared to not using any immunosuppressive therapy. So it could be safely used. So this established at least it works in this thing. So the second trial which came was the Mentor trial, where they tried to establish whether, because the CNI was in the West, it has been always been that there is a lot of fear of using cyclophosphamide, because cyclophosphamide has been thought to have a lot of side effects associated with it. So many of the centers would use either CNI therapy or not. So the Mentor trial actually compared rituximab after a run-in period of about 3 months. They randomized patients to 1 gram, 2 doses of rituximab to CNI therapy, which was, and then they continued and see at 6 months what happens. At 6 months, if the reduction in the proteinuria was not there, to less than 25% was thought as therapy failure, and they were not taken out of the trial. And those who had a response, they were given an additional dose also. So let's see what happened here is that when they used this therapy, that is day 1 and day 15, 1 gram course of rituximab, at 12 months, if you see, there was a non-inferiority of the response compared to cyclosporine. And even at 24 months, it appeared to be superior because there are more patients go into remission as time goes by, and serious adverse events were much lower with rituximab compared to cyclosporine. So this established that 1 gram dose of rituximab given on day 0 and day 15, and you followed these patients, a significant number of them would go into remission at about 12 months. Important note is that you have to follow these patients longer because it takes for them longer to go into remission, and you may not see them going into remission much earlier if you did do a long-term follow-up. So again, this established was better than cyclosporine. So then the question came up that, okay, it's better than cyclosporine, but the gold standard, at least believed in many of the Italian centers and also in India and many places, is that one should use cyclophosphamide. So that trial was a Starman trial. Starman trial was actually not a perfect comparison trial because they use glucocorticoid and cyclophosphamide compared to using CNI initially for 6 months and then giving them rituximab. So this was not really a perfect comparison, but show that use prednisolone and cyclophosphamide, it did better than the sequential therapy with tacrolimus and then using rituximab. And at 24 months, the complete or partial remission was 84%. I'm sorry. And at 24 months, again, the complete remission was 60%. There was significant depletion of the antibodies if you use cyclophosphamide and methylprednisolone. And at 6 months, about 92% patients had depletion of antibody compared to when you use a sequential tacrolimus and rituximab therapy. So again, the argument was this was not a perfect study because most centers would use cyclophosphamide upfront and not use tacrolimus and do that. So then came the rituximab cyclo trial, the RI cyclo trial, which compared rituximab with 1 gram, 2 doses with glucocorticoid and cyclophosphamide to begin with after initial run-in period with RAS inhibitors. And then they evaluated at 6 months and then they followed these patients. So if you see this in trial, this was actually not a perfect trial in the sense that this was an exploratory trial because they did not use numbers to find significant superiority of one therapy over the other, because numbers if you see are the 37 and 37, 2 of them. And at if you see the outcomes of these patients at 12 months, complete or partial remission was seen in 62% and 73%. The probability of remaining at complete or partial remission was 85% and 81%. And the relapses were 13% and 22%, and adverse events were nearly similar. So the authors concluded no signal of benefit or less harm associated with rituximab versus cyclical corticosteroid cyclophosphamide regimen in the treatment of membranous nephropathy. Now, this is a visual abstract prepared by some other people compared to what the authors wanted to see. In the author's opinion, when they presented their abstract, they said that our pilot study shows that completing a larger trial may be challenging. So they think that now that a cyclophosphamide and prednisolone are coming equal to rituximab, it's unlikely that we will have superiority inferiority one therapy over the other. While non-significantly different, the point estimate of 1 year probability to complete remission was lower in the rituximab arm. Throughout our follow-up, the probability to achieve a partial complete remission was similar in the study arm, and cyclical regimen tended to induce complete remission earlier, and rituximab appeared to have a delayed effect, and the frequency of adverse events were comparable. So I think we have really come to a place where there might be an equipoise between using cyclophosphamide prednisolone versus rituximab. Both can be used, and possibly it looks like there is cyclophosphamide prednisolone that might be an earlier reduction in the antibodies and maybe an earlier remission rate, and which may be similar. So this is the trial that we did at our center, and the lead author is Sandhya, who was the fellow at that point, and she was a fellow at that point. And we randomized 68 patients into two arms, that is 34 to the cyclophosphamide and corticosteroid, and we used rituximab. Rituximab we used as a lower dose, that is about 500 milligram IV on day 0 and day 15. And at 6 months, we found that about 50% in the cyclophosphamide arm had remission compared to 44. And at 12 months, again, a little bit more in the cyclophosphamide compared to rituximab. And CD19 counts, though, remained lower than 1% of both 1 and 6 months. And you can see here that 35% over here, reduction in the PLA2R levels. But there was this infection in the cyclophosphamide with infections and leukopenia and hyperglycemia. So there were more side effects seen with cyclophosphamide compared to that with rituximab, though there was a little higher rate of response to that. So this pilot study could not prove non-inferiority, but suggests that low-dose rituximab could achieve sufficient B-cell suppression and short-term remission rates comparable to the standard, that is the methylprednisolone and cyclophosphamide therapy. So putting all together, there are a lot of pros and cons of using both these therapies. So cyclophosphamide, the pros are in use of several decades and familiar to most of the nephrologists, more readily available, particularly in the developing country, established efficacy in several randomized trials, and maybe more effective in patients with high PLA2R titers, and may achieve remission faster. However, the cons are there's significant myelotoxicity, infertility with the cumulative dose. Most of the patients, if you use the standard pontifical regime, which require about 10 grams to be given, which can have a significant effect on the fertility and long-term, maybe malignancy also. And of course, with steroids that you get a Cushingoid features and other things, and no need for frequent laboratory monitoring because you need to see the counts, and fixed dose regime, they cannot be tailored to the patient needs. However, with rituximab, it is established again in several trials, as we saw, intravenous dosing, so adherence is not a problem. Favorable side effect profile can be tailored on basis of the antibody. You can dose the patient again if the antibodies are rising or if they're not going down, and better options for childbearing patients and patients with reproductive age group. Of course, there can be infusion-related and insurance coverage, but in our country, the cost would also be some of a dampener to use rituximab more widely, as has been, and cyclophosphamide appears to be cheaper therapy. So all in all, how do you do it? So the KDIGO tells us that in a low risk wait and watch, in a moderate use, you can either use rituximab or use CNI because you don't want to use cyclophosphamide. But in high risk patients, either use rituximab or cyclophosphamide or CNI plus rituximab can be used, either of them. But probably it might swing towards either rituximab or cyclophosphamide, depending upon the patient profile and the risk appetite that we have. And of course, in a very high risk patients, cyclophosphamide still remains therapy which can induce remissions much faster. So again, it is important to monitor the therapy because if they are PLA2R positive, it is easier to monitor them. They monitor the therapy at 3 months and see whether they are responding or not responding. If they are responding, then maybe no additional therapies are needed, and just follow these patients. If they're not responding or no change, then immediately give additional doses of rituximab. Important thing to note is that several of our trials actually did not give additional doses of rituximab at 6 months. They gave it at 0 and 1 in the Mentor trial. They did not give it to everybody at 6 months. And a lot of the investigators and authors felt that if you do dosing at periodic intervals, the rituximab, and the safety has been shown, and probably the number of patients going to remissions may be higher. So this is one exploratory thing which people think that in the future, there may be more maintenance therapy with rituximab compared to what we are seeing today. And of course, the plateau Rs are increasing. And if you use cyclophosphamide, then you can change to rituximab. If you use rituximab, you can change to cyclophosphamide and see if the patient responds to these therapies. So this is about the membranous therapy. In minimal change disease and FSGS, we have very small multiple trials available, but it has been shown in all that rituximab is effective only in steroid-sensitive nephrotic syndrome. It doesn't really work in steroid-resistant nephrotic syndrome. So after you're really given a good trial with in a steroid-resistant nephrotic syndrome with steroids, and then even with maybe cyclosporin or tacrolimus, and if they are not responding, it is unlikely that they'll respond to rituximab. But in steroid sensitive or steroid dependent patients, there have been numerous trials to show that frequent relapsing or steroid dependent minimal change disease in FSGS, if you use these therapies, then one can get them off the steroid or make them steroid free for a period of time, so that side effects of steroids are not there. And also they can maintain a remission for a longer period of time. Despite giving rituximab, they're likely to relapse. About 30% of patients will relapse. So you might have to do frequent dosing with rituximab if you have to maintain. Whether to use rituximab upfront on day one compared to corticosteroids, you can avoid corticosteroids completely. There are currently trials running, there are currently trials underway to try to see if you use rituximab upfront, what happens. And maybe we will have much more data to know whether we can avoid steroids completely and they would respond to rituximab. And there are some small studies in children where they have shown that upfront use of rituximab is equally effective as compared to corticosteroids. So some of the novel, just to end the talk with it, that there are some of the novel B-cell therapies are going to remain, and we have got another therapies like the ofatumumab available in our country, but very expensive, which acts not only which acts on a small loop of the rituximab molecule, or the CD20 molecule, and partially on the large loop, and rituximab acts only on the large loop. So we have the obinutuzumab, which a deflucosylated molecule, which is supposed to have a higher antibody-dependent cytotoxicity. And of course, there are many therapies now coming in the plasma cells, which are the final production of the antibodies. And we have also some of the growth factors, belimumab, which are also being tried in patients who are resistant to the therapy with rituximab. So in summary, recent trials in both ANCA vasculitis and membranous nephropathy have shown that rituximab is an effective and safe alternative alkylating agents. Long-term data on prevention of end-stage kidney disease and patient outcomes are needed, because it takes about 10 years for the patients now to go into end stage. And so for the comparing what really happens 10 years down the line is important to know. We also do not know how rituximab will behave when you dose them multiple doses over a long period of time. Rituximab is also an effective steroid-sparing treatment for steroid-dependent, frequently relapsing minimal change disease and FSGS, and novel B-cell therapy are being considered in resistant cases. I will end here, and thank you for a very patient listening.
Thank you, sir, for the excellent presentation. Personally, I would like to ask some questions to sir, that when you label as rituximab resistant in membranous nephropathy.
So in membranous nephropathy, if you have plateau R positive, you should see some reduction in the titers at about 3 months. If you don't see any reduction in the titers, actually titers presage the proteinuria reduction. So if your titers are not going down, proteinuria is unlikely to go down. If you don't see it at 3 months, then you have to really ask the question, should I need to give an additional therapy or wait a little bit more longer and see what happens? At 6 months, you must really see some reduction. If you don't see it at that point, that means that the therapy is not likely to work and you might have to add some additional therapy. If you're following the proteinuria and you're not able to follow the titers, then it might take longer. Then you need to really wait for 6 months to see the proteinuria reduction is there or not. If there's no reduction in proteinuria at 6 months, then you can ask the question whether you need to do a redosing with rituximab if you're dosed it earlier, or if you're using the Ponticelli regime and there's no reduction, then to see whether you want to give any additional therapy with any other agent or not. So at 6 months, you have to wait, and 6 months to 12 months would be the period of time. So if you're doing the titers is now easy to do, so maybe that's one more clue if it is plateau R positive.
Do we have the fixed dose regimen for all patients, or should we titrate according to the plateau levels or the initial proteinuric levels?
our own practice is not to use rituximab as shown to give them multiple doses in membranous at every 6 months. What we have been doing is that I dose them initially, like the Mentor trial, I give them 1 gram, and then after 15 days, give another gram, and at 6 months, see if the titers are really down, everything is going fine, proteinuria is down, then wait and watch and see. We haven't really moved to a fixed dose regime still. We are looking closely what happens in our cohort and what happens in the literature to see whether do that. One is it is expensive. Secondly, we have seen many patients remain in remission for a long period of time without additional doses. So I'm personally favoring right now, or maybe it will change if the data changes, that follow the titers, follow the patient and redose them. If the renal function is stable, a little proteinuria coming up again versus prevention of the proteinuria appearing, I feel that we might end up using very few doses compared to a fixed dose regime, but we can watch and see. I would like to hear from others if.
Same membranous nephropathy, when you were giving rituximab, what dose of steroid you were giving at the initial start?
I generally don't use steroids if you're using rituximab. Only in one patient recently I've used where he had very high titers and I thought I want to use it. So I thought we give them a steroid along with it because he also had a DVT, that is deep vein thrombosis. So I thought maybe get the titers faster down and gave steroids. But generally I don't use steroids.
Otherwise you're not.
No steroids. So that's one advantage.
Shishir bhai, it was really an excellent presentation. In your experience, when you were giving 2 doses of 1 gram rituximab at 0 and 15 days, was there increased incidence of opportunistic infection?
In the study that I showed, that there were a lot of patients. Actually, in the cyclophosphamide group, you found more infections compared to that in the rituximab group. And initial studies, we were using 502 doses. Now, recently, we have moved to 1 gram, 2 doses, because we felt that maybe the number that we did not respond or difference that we found with cyclophosphamide was because of underdosing. And we thought that, as has been mentioned in literature, that initially when there is a heavy proteinuria, when you give rituximab, part of it might come out into the urine. So you might not have an adequate response to it. So that's why 1 gram, but a lot of people feel maybe 500 is still okay. As far as the infection rate is concerned, it's much higher with prednisolone and cyclophosphamide. We saw a lot of herpes zoster. Of course, you see all the, and also the skin with steroids that we use and the doses that we use in our country, we saw a lot of skin fungal infections, and many of them would require significant treatment with either with itraconazole or fluconazole. So I think we all understand that, but when we do a trial, you really document, and there was a really significant difference between the two.
We have some panelists also for this discussion. May I invite Dr. Rajesh from Jodhpur, Dr. Manish Kumar Jain from Kolkata, Dr. Javed Vakil from Ahmedabad, Dr. Jagdeep Shah from Ahmedabad, and Dr. Tanmay Pandya from Faridabad. I have some questions for the panelists also. We have discussed about role of rituximab in nephrotic syndrome and vasculitis. Now, I'll ask Dr. Manish to have a comment upon the role of rituximab in lupus nephritis. I'm sorry for that. You can answer that.
In lupus nephritis, actually still what we are using is cyclophosphamide based therapy and MMF. We still prefer these drugs, and rituximab we often use for the refractory cases. The patient is not responding to the cyclophosphamide or MMF based therapy. So in our experience, we used in one patient who was younger, 20 years, and she not responded to the cyclo and MMF. After that, we use rituximab. She received 1 dose of rituximab, and in the second dose, she developed reaction to it. So we withhold the rituximab. And later she put on triple immunosuppression, but she not responded to that. Now she's on dialysis. So yeah, reports are there to use in especially in lupus, in refractory cases of lupus, we can advise rituximab.
Want to add,
Any other
I
panelists
have,
want to comment?
I have comments on this. I have a few patients of mine which initially female and initially refractory to steroid, MMF, even endocrine also. And then we tried with the rituximab. It was like 5 years back. And after that, patient responded very well, went into remission, and she's got pregnant after that and delivered boy. And few days back, she came with me again after maybe 2 years of interval, and she was under remission. So that's good to respond with the in such cases.
Maybe the childbearing age and patients who are not very much having a class 4 with rapidly progressing glomerulonephritis can be,
So
we can
it's good for the
use
time.
rituximab. Now, the next question goes to Dr. Tanmay, that we have heard about Mentor trial, the recyclo trial. Has your attitude or prescription changed as far as membranous nephropathy is concerned?
Some product of the trials has been that yes, the use of rituximab in treatment of membranous nephropathy has increased. In my practice, it's fine. So in my practice, I do find that treating the patient with rituximab for moderate or high risk of membranous nephropathy progression, rituximab is very convenient. The treatment is administered in a short span. Steroids can be spared to a large extent. And so the compliance is good. Yes, of course, it takes some time to show response in terms of proteinuria. And if the patient has been well counseled beforehand, then that does well. Now I have like a few patients who have maintained remission for beyond 2 years. One of my patients was recently showing a relapse after nearly 3 years of rituximab therapy. And so encouraged by the first response, I have treated the patient again with a second course of 1 gram at 2 weeks interval. But yes, rituximab, even though the data suggests that it is probably non-inferior to cyclophosphamide and steroid combination, the cyclical cyclophosphamide steroid combination, the convenience and the safety profile or the side effect profile has made one choose rituximab over cyclophosphamide and steroid.
The message is that both patient and the doctor should have patience in using rituximab while treating membranous nephropathy. Now, we've already discussed the role of rituximab in vasculitis. What is your experience, Dr. Jagdeep, regarding use of rituximab in vasculitis?
Rituximab in vasculitis, like when it is an severe form of vasculitis and you with renal dysfunction, and so that time with in methylprednisolone, and that we are using it. And in maintenance therapy, this needs to be still followed, whether because vasculitis is likely to be relapsed. So as the Dr. Shishi said, we need to see whether maintenance doses of rituximab would reduce the incidence of relapse.
My next question to Dr. Shishi is that
couple of things to this vasculitis. Most patients that we nephrologists see for vasculitis are generally rapidly progressive renal failure. And even though rituximab is good enough, I do tend to use cyclophosphamide more often along with methylprednisolone for these high-risk patients or those who are more advanced in renal dysfunction. For example, those who are almost at the verge of requiring dialysis or actually requiring dialysis, because there is some suggestion that patients cyclophosphamide may be preferred over rituximab.
maybe the message is that
Plasmapheresis for ANCA-associated if the patient is on dialysis. Yes, for dialysis dependent patient, but not for GBM. And if the patient has some pulmonary involvement.
That patients of severe vasculitis might benefit because there's evidence that is much superior to it. And moreover, it does not interfere with your plasmapheresis because rituximab, then you have to really tailor your plasmapheresis accordingly so that, and so it's much easier. It's important to use cyclophosphamide prednisolone in patients who have severe vasculitis. And then in maintenance, maybe one could consider using it.
My next question to Dr. Shishir is that, do as a nephrologist, we have to fear of more of side effects in nephrological cases as compared to the non-nephrological cases in using rituximab? Because with rheumatoid arthritis, okay, there is hardly any infections, or they use at a multiple doses and a very high dose. So can we follow them, or do we have our own protocol for?
I think we need to gather more experience and then see. And I think the easiest disease where we could actually gain experience is membranous nephropathy, because that is where we don't have too many other comorbid or co-immunosuppressions. In transplants, in lupus, and everywhere else, we're going to have other immunosuppression. So you really do not know how the drug is doing, how it is working, how things are happening. So I think to learn the drug, my personal feeling is to start with membranous, the dosing that people have recommended, and see whether our patients are doing well on that. So that's my take.
And do we need to measure rituximab levels?
I don't think it's available, and I haven't done it. Okay. As regards anti-rituximab antibodies, there are situations where they do say, we have never ordered it or seen it or been done in our country, but that is a suggestion that you can still get it. And there is also a suggestion, even if you have antibodies, if you dose it, it still works. So I'm not sure whether routine monitoring is needed, but in patients who do not respond or who are resistant, and you want to go on to another therapies and try to find out, maybe there is some role of anti-rituximab. But now that we're getting better, the cost of maybe the ofratumab may come down at some point. It is humanized, so less likely to have antibodies to it.
I have a quick question and comment if you can allow. One thing is the comment is that whenever a patient, there's always a difference of opinion when a rheumatologist and a nephrologist treats lupus, because nephrologists are very aggressive and they do a biopsy and then they treat lupus. Whereas rheumatologists, you see, they keep on treating it till the time the patient lands into a kidney dysfunction. So that is the first thing. Secondly, would your treatment change according to the class of lupus?
In the sense membranous versus
no, in lupus, especially if you're talking about rituximab in lupus, I mean, would your treatment change according to the class of lupus?
Yeah, it would, because in membranous lupus, it behaves more like a lupus otherwise. I mean, membranous otherwise. So rituximab use may be much more easier to do it there on. In class 3 and class 4 lupus, at least the trials were not as satisfactory with rituximab compared to the standard of care that we are currently giving as for the trials. But in the trials also, it was shown that those patients who had received cyclophosphamide before and then Ritux was used, in that subset of patients, they did better. So maybe in patients who are refractory, as some people said that they've given cyclophosphamide and they are now really, patient is still not responding. Maybe in them, on the base of cyclophosphamide, if you use Ritux, they might have a beneficial effect. And with a lot of rheumatologists also whom I talk to, they tend to use Ritux after cyclophosphamide, and they seem to show some better.
I would like to add two trials. One is Alan Bliss trial, where they have tried belimumab in lupus nephritis with beneficial effect. And another is voclosporin, use of voclosporin in lupus nephritis. And it has also shown beneficial effect without, it does not require drug level monitoring, unlike cyclosporin.
So we have anybody wants to ask any questions to the panelist?
I want to ask Dr. Gang regarding recurrence of membranous nephropathy in post-transplant patient, role of rituximab.
If the patient, a few things, the patient is plateau positive and they are more likely to recur after transplant, then response rituximab in the post-transplant period is poor. Personal experience I have patients who had a recurrent transplant for all tag and another. Patient had a remoteness problem. Rituximab is approved. And research is also not very encouraging because post-transplant is usually not as good as immediately candidates. But I will before
So I was using on the different problem and having a product with transplant. And the biggest difference is our patients and transplant are multiple different states. And other than they may have been through an office and the witness and transplant, particularly SPS. And the experience I've got with the cuts is different. So the question I have is, how do we have this start? I still have patients.
First, as you said, that patients are already on immunosuppression with getting this FSGS here is but in membranous somehow I don't know what are these what is clinical experience. So the only thing is that the significant neutropenia can happen in immune system. So using anti-inflammatory also can maybe at some point need to be launched and get it off. And again, I would and I tend to use some prophylactics for CNV because at the same time they might come up and also use Safran. Safran of late we have been using post-transplant for a very long period compared to what it's not the right. So when you intensify, I always keep in mind
they're all very valid. Patients just so the adverse events are not pretty clear. A good discussion on the role of predictive and methodology. And that is obviously that as far as results are concerned, in mild to moderate cases, rituximab and cyclophosphamide are practically the same. And in that deteriorating renal function, obviously we have been using cyclophosphamide in long way. So we do not have a choice right now. We continue doing that, but obviously more and more studies may give the answer to us. Thank you, sir. Thank you all of you for the wonderful discussion we had.
Thank you very much for such a good presentation.
Good. On 100% one-year patient survival and 99% one-year graft survival. Taking the allogeneic MHC antipeptide and presenting it on the self antigen presenting cell. Now that has to be the presenting cells exist, which is 3 months-ish. So this is where the acute rejection is coming from. I'll leave you to read the paper. The second paper is you The paper is, I've accepted it about 4 days ago. So it's not yet through the system, but will be coming. And that is looking at T-B cell collaboration in autoimmunity, the conversation we've just been having, in infection and in transplantation. So with 3 papers, you can be much wiser than all of your registrars and provide them with that information to read. Where are we going with perfusion? Normothermic perfusion systems. This is a review of where we've got with taking essentially body temperature blood and continuing to perfuse it through the organs with the goal of being able to allow repair of the organ, with the goal of being allowed to better evaluate the organ over time, and with the goal of being able to intervene therapeutically in that organ. So some big goals, and there's some quite impressive achievements. The one I pull you to is the Weiss perfusion machine that was published from Switzerland. A liver perfused for 68 hours. 68 hours. That's a game changer for liver transplantation. You can keep a liver going for days and transplant it. And that report was the 1-year survival of that liver. Astonishing. So there are some real game changers coming in normothermic perfusion. You need to keep an eye on them. They will change some of the other organs more than they will change kidneys. It's expensive, it's difficult, it's tough. Got a lot of expertise associated with it. It's not easily spread out, but when we can pull a marginal kidney into a good kidney, that will be a game changer. When we can change a kidney that's been damaged by ischemia for 2 hours into a kidney that you can use half the time, it's going to change the donor field. Watch normothermic perfusion happen. Now, Australia has taken with great enthusiasm to the virtual cross-match. And having run a tissue typing laboratory for many years, I'm worried about that enthusiasm. In the United States, they have used the virtual cross-match for some time, and this is data coming from the UCLA using their exchange. And what I'm showing you here is the coefficient of variation, the variation between laboratories based upon the MFI. And what it shows you is really high MFIs, very strong antibodies, not so much variation. And you're not going to get the wrong answer from strong antibodies. But when your MFI is under 2,500, look at that variation, huge. So with weak antibodies, you get different results. Now, they then went on to compare a real cross-match with a virtual cross-match. And what does it show? It shows us that when you've got a really high MFI, the virtual cross-match is pretty good. The flow cross-match predicts the virtual cross-match, and the virtual cross-match predicts the flow cross-match. But when you've got a low-level antibody, it doesn't. Now, who of us is shocked by that? Not one, but the labs might be. So let's have a look at what it really means here. This is virtual T-cell cross-match on the left and virtual B-cell cross-match on the right against the physical flow cross-matches. I just pull up those 2 sets of statistics there. So when the virtual flow cross-match is negative, the T-cell flow cross-match was positive 16 times out of 112. Oops. 15% of hyperacute rejection you weren't predicting. Well, I don't think this is such a good idea. And the other way around, we're stopping 13 transplants because the virtual cross-match is positive, but the flow cross-match was negative. So they don't matter. You're predicting a result that's not there. So you're stopping transplants that you can do.
I spent my whole research career trying to do the reverse of that. So be careful of the gurus of virtual cross-match. Same is true of B-cell cross-matches. Read the paper, it's fascinating. Epitopes, ECLATs. Everybody heard about ECLATs? It's the new thing. It's what the labs want to move you to because it's much more complicated. You need a big computer program. It's much more fun. So Anna Tambor has put a nice paper together looking at what we can use ECLATs for and what we can't. So ECLAT is those little yellow things. They are different bits of the HLA molecule that have some, but not necessarily any, effect on the binding group, the peptide binding group, which is shown here with the peptide in purple. And on the right are the footprints of antibodies that react to those parts of the molecule. And you'll see that sometimes they combine across two ECLATs, sometimes they combine across the peptide group. But they're a bit of a mess, actually. And so their conclusion, and I leave you to read it, is be very careful of ECLATs. They were designed to look at immunological risk, at immunological likelihood of a cross-reaction between different mismatches. They were not designed for allocation algorithms. And people are trying to take them into allocation algorithms, and they should not do so. They're not designed for it, they're not for it, and they don't predict it. And I just showed you actually some examples of where a virtual cross match will predict something that's not there. And the reason that it predicts it's not there is because those efforts sometimes don't work properly. Now, what about other antibodies? Rejections. I had a HLA identical sibling transplant who I think took our enthusiasm to reduce his immunosuppression just a little bit too far. And he rejected his transplant on about what he was supposed to be on 50 milligrams of azathioprine and 5 of prednisolone. I suspect he wasn't taking it, rejected it. But interestingly, he developed an absolutely whopping great antibody titer to a different antibody, a different antigen, one of these natural antibodies, the AT1 receptor antibody, who we then had a second donor. And are we going to do this transplant now? Will this antibody react with the second donor? We knew the HLA didn't, because he didn't produce any HLA antibodies. But is this one, which killed his previous kidney, going to react with the next transplant? Totally unpredictable. We've worked hard to get the antibody down. This is a 4-unit collaboration looking at those natural antibodies. And I'll just draw you to the composite endpoint, grass survival, key rejection, death, etc. And show you here that the top graph is no pre-transplant natural antibodies and no donor-specific antibodies. The bottom is both high pre-transplant natural antibodies and high donor-specific antibodies. And the middle two are high one or the other, high donor-specific antibodies or high pre-transplant natural antibodies. And this paper also goes on to look at the adverse impact of developing high post-transplant natural antibodies. So there's something else here that we are going to have to keep an eye on to defend better results. Now, I do want to talk to you about donor-derived cell-free DNA. Somebody's going to be selling it to you, or they already are selling it to you already, as the answer to everything. Better than sliced bread. Well, not quite. So this is an overview, a clinical overview for clinicians. So if you want to stay on top of it, it's a good paper to read. And I've got you the summary here. Donor-derived cell-free DNA is released from the allograft into the blood when it's damaged, and it comprises a small proportion of total plasma cell-free DNA, which you're releasing all the time. It's got about a 2-hour half-life. It accounts for less than 0.5% of plasma cell free DNA in a kidney transplant recipient. So the normal results less than 1.5%. Elevated results occur when you damage the allograft almost from any outcome, but it does seem to be particularly occurring in antibody-mediated rejection. A normal result in the context of allograft dysfunction reduces the probability, careful of those words, of detecting rejection. Only reduces the probability. And then the other question is, if you've got stable graft function, should you be doing a test to see if there's something going on subliminally? And I'll readdress that question in a moment. So what they did is they put together all of the results here of cell-free DNA from donor-derived sources, looking at positive results. Most of those are greater than 0.5, some of them are greater than 1.0. And you see here that you've got more or less what you'd expect. If the specificity, looking at the left-hand panel, if the specificity is up towards the 100%, on the whole, the sensitivity is lower. Now, as if you're looking at only very high levels of donor-specific cell-free DNA, then most of them are going to be rejection. And you can see there on the right the positive predictive and negative predictive values. And you see the positive predictive value is pretty poor when the negative predictive value is pretty good. So again, clinically, this isn't terribly useful. You can't replace the biopsy with this, which is what some of the advocates are going to tell you. So here's the question. If you've got somebody with preserved kidney function, should you monitor them with cell-free DNA? And the answer is, well, you as clinicians can take it as I do, I'm sure. If you've got a high level, you've got a 17% chance of there being a rejection event occurring in the next 3 months. If you've got a low level, it's 5%. What are you going to do with that? You're going to treat on it? And if it's in the middle, by the way, it's in the middle, 12%. Its donor-specific antibody prediction was not very high. It wasn't common, and it wasn't different between the groups. So you can't monitor donor-specific cell-free DNA and hope that you can then do an occasional HLA test. Don't use it to monitor stable function. Now, Phil Halloran's done some nice three-way studies looking at his molecular microscope on the one hand. What does that tell you? Histology, bam, what does that tell you? Versus the cell-free DNA. And I think that dot plot gives you the best answer to what this does. That line is at 1.0, not 0.5, as some of the studies were done. And it shows you there red dots for antibody-mediated rejection, green dots are T-cell-mediated rejection, and yellow dots are mixed. And these are a stack of indication biopsies. And they show you that high cell-free DNA, both the actual amount on the left-hand side and the percentage on the lower axis, give you a pretty clear indication that if you've got both the amount and the percentage increased, you're going to have rejection. There are relatively few blue dots in there. How well does it correlate? And you see in the bottom right-hand corner, if the molecular microscope, the DNA, the RNA that's in the biopsy, the histology, the cells you can see what's actually happening physically, and the cell-free DNA reasonably correlate. So if you've got no rejection on either the MMDX or histology, the mean cell-free DNA is low and the quantity is low. If you go to the other end where everything is showing rejection, then the mean is up 1.78 and the quantity is up to 92. And then you've got the discordance in the middle, no rejection from the MMDX, rejection histologically, and then vice versa. So Phil is obviously using this to say, well, our truth is as good as anybody else's truth and better than cell-free DNA. indication biopsies, not protocol biopsies. And then he's gone on to look at what happens in patients who have antibody-mediated rejection without the antibody. In other words, you can't find the DSA, but you can see on histology, and he can see on his molecular microscope, the pattern of antibody-mediated rejection. And the answers are here, really. If you have got DSA negative antibody-mediated rejection showing histologically, then the cell-free DNA does indicate damage is occurring to the kidney. So maybe that's actually quite useful there. That left-hand DSA negative group. A lot of those blue dots are up the top there. A lot of the grey dots down the bottom. So that might be one place to help. Now, I first produced this nearly 20 years ago. Actually, I did write it up about 20 years ago, but this picture of how you put this all together, the influences on a graft, chronic donor disease, acute donor disease, ischemia, acute T-cell and antibody and mixed rejection, subclinical rejection, chronic, what I call humoral natural chronic antibody-mediated rejection, CNI toxicity, and how all of those things impact on the histology of the graft progressively, leading eventually to tubular atrophy, interstitial fibrosis, arterial hyalinosis, glomerulosclerosis, and then late change in serum creatinine. Well, it has amused me to watch others. Firstly, BAMF has become much more stable, and there is a nice analysis that we published in 2018, which gives you all of the data on BAMF and looks at the various lesions that you have. So here's a recent paper, and it's still online first and not assigned to an issue that we published, which is why that the page numbers are not shown. What happens with T-cell mediated rejection, and what's the role of surveillance biopsies? Let me take you through this if I can. First of all, if you have inflammation, there are other causes of inflammation that you need to consider. Secondly, you can look at gene expression, you can look at cell-free DNA, but in the end, and it is a pathologist writing this paper, you've got to look at the biopsy. And I think I will concur with that. If you've got T-cell mediated rejection, you should treat it. If you've got treated rejection, you should follow that up with a protocol biopsy to see if you were successful. And the reason you should do that is going to come up in a second. If you've got isolated interstitial inflammation, I1, without tubulitis, no impact. You've got T1 with no I, also, you can ignore it. Don't treat it. And you don't need to treat it post an acute rejection episode or on a protocol biopsy. But if you've got borderline rejection, then as we showed in 2001, 2, that progresses slowly to fibrosis. And that's why we lose 60% of our long-term grafts from chronic angiographic nephropathy, because it just rumbles away under the surface until finally the creatinine moves to go, whoa, I better look at this. Hasn't changed. So borderline on protocol biopsy can resolve spontaneously. We've shown that, but only early on when you've got relatively high levels of immune suppression. Usually, if you've got an I2 with a T1 or a T2, near T2, you need to treat it. And if you don't treat it, you should follow up in about 3 months to make sure it's not worse. Because the creatinine's not going to guide you. The creatinine's not going to change. Not that year. It's going to change in 3 years' time. Now, we have got some uncertainties about what do you do about the B lesion, and I'll show you that in a second. And where are we going with treating chronic antibody-mediated rejection? So we have still got some results. Now, the thing that amuses me most is here is Phil Halloran, who bugged me for years about saying, no, cyclosporin is not nephrotoxic, don't worry about it. And here he is, look at him. We hypothesize, based on the reciprocal relationship between hyalinosis and TCMR, looks that the more calcineurin inhibitor you've got, the more hyalinosis you've got, and the less calcineurin inhibitor you've got, the more rejection you've got. Thank you, Phil. Took you 20 years to accept what I said, but I'll take it. And this is data that he's shown in these transplant biopsies and the time it takes for molecular T-cell mediated rejection to lead to histological tubulitis, atrophy, and fibrosis and outcomes. And you can see here that only early antibody-mediated rejection is postponed in terms of the development of a poor outcome. The rest all follow. Now, vascular rejection, Brian Ankerville at our center with the pathologists looked at the V1 lesion, isolated vascular rejection. You see it sometimes in a biopsy. You need to have about 10 glomeruli in the biopsy to have an adequate sample. And if you've got vascular rejection, you've got a poor outcome, even if you treat it. But if you've got an isolated V lesion, but no interstitial inflammation or tubulitis, your result is intermediate. So treat it. Strong advice. You get a lymphocyte sticking to the inside of a blood vessel or on the blood vessel wall. It's rejection, treat it. It's not going to be good for the kidneys. So I'll finish on the last problem, which is COVID, vaccination and COVID. And this is the second paper we published from the UK group. It's about 40,000 patients. It's a really good example of how you pull national data together from different data sets to give you an answer. This shows you what happens to vaccinated transplant patients with COVID. So down is good and up is bad. So what this shows is that compared to Omicron, a vaccinated patient had worse outcomes from, that is mortality, if they had the Alpha or the Delta strain. We know that. It's not a surprise. Lung transplants, elderly transplants do really badly, even if they're vaccinated. And if you look at the vaccination cascade on the left, you see that there's a basic message. The more vaccine, the better. The more vaccination, the better protected. This is probably the best evidence. This isn't antibodies developing after a vaccination. This is, did vaccinated patients die when they got COVID? There are some criticisms on it, but it's the best data I've seen. Vaccinate often. I had my 5th vaccine about 2 weeks ago. So thank you for the opportunity to come and talk. And I look forward to hearing from all of you in due course.
Thank you, Professor Jeremy Chapman, sir, for the comprehensive presentation. Please join us for panel discussion, sir. I would like to invite the panelists on the stage. Dr. Umapati Hegde from Nadia, Dr. Sonal Dalal from Ahmedabad, Dr. Vishwanath S. from Bangalore, Dr. Vishal Saxena from Delhi, Dr. Subho Banerjee from Ahmedabad. My first question to Professor Chapman. Sir, commonly in India, we use thymoglobulin and IL-2 receptor blocker as an induction therapy. What would be overall indication for alemtuzumab, where it should be preferred? Any comment on use of alemtuzumab?
Well, we don't use it, I showed you. We haven't used it. There have been 1 or 2 small trials. So I'm going to say it's not necessary.
Okay.
To get the results that we've got. We use ATG in about 15% of patients, as I showed you. They're high immunological risk patients. There are other issues around cost, which may bear here. Alemtuzumab was essentially free for quite a long time. That cost issue did not impact on us.
Dr. Umapati Hegde, what are the factors affecting transplant rejection?
Basically, we'll have to modify as risk, whether it's moderate risk, minor risk. So patients who had first transplant, going for second transplant, they are high risk because they already have an antibody and they have received the multiple blood transfusions or multiple pregnancies, or if they have recent infections or viral infections, it may also increase the chance. Or if they had the multiple viral, even a BKV or anything in the past, they have. So the infections and the multiple blood transfusions, pregnancies, they all increase the antibody and they have a higher chance of getting the rejection. So in these patients, we have to be very careful, and otherwise to get rejection. These are the patients who need either flex therapy if they have a cross-match positive, or we can go for an alternative way of pair exchanges, or if there is a cross-match is negative or the N5 is less than 1,000, we can go for genetic induction and we go.
Dr. Vishwanath, how we should do screening for infection before transplant, and what is the overall difference in infectious complication between depleting and non-depleting therapy?
Generally, if somebody is high risk and they're using hair induction depleting agent, then we should probably be more careful. Of course, all of us screen them for CFA and they are on depleting agent. We are not routinely doing the BKV, though it is a recommendation now we have started doing more BKVs, especially with high risk second transplant, whenever there is any practice on BKV. Most common infections which we screen is of course CMV, prophylaxis, BKV, and of course EPV we are not doing much because we are not doing and of course, as I mentioned, we need to keep them for prophylaxis, including
Yes, Professor Chairman.
Yeah, I just wanted to follow up on that comment in the previous session about long-term cotrimoxazole therapy. We have reported epidemic pneumocystis as opposed to endemic pneumocystis. There are at least 20 reports in the literature of epidemic pneumocystis. We had thought that we had got control of our epidemic. We went back to selective long-term cotrimoxazole and we got a second epidemic back. I think the change has been sociological rather than medical. I don't think it's the organism that's changed. I think what's changed is we put transplant patients together in clinics much more frequently and in much larger numbers now than we did in the 80s and the 90s. And when you trace contacts across patients, you see that your patient with pneumocystis contacted a patient who had pneumocystis and went to the hospital. They contacted them in the clinic 3 months ago. And so we've gone to permanent cotrimoxazole therapy. It's not expensive. It also reduces UTIs, but it's the only way of abolishing pneumocystis.
In fact, everybody is high risk and use ATG because we also experience even after COVID and even on individual therapy, we can't really slow down. 2 years we had. So now we are
continue lifelong. We're not stopping after 1 year.
In India, the parents and spouse, they are common living donor. Dr. Sundar Madam, what should be the induction therapy in parents donor versus spousal donor?
Definitely, the induction would depend on the, you have this, so if you have a couple of match, like, the parents and the donor, like, to give this induction. Sometimes what we can follow is modify the dose of induction agent. But preferably if the parents are more than like to use activities of the patient, the donor is minus from the sensitive to basically sensitive to
Yeah. We have two depleting therapy available in India. One is the thymoglobulin and other is the grapholon. What will be your comments on selection of two different depleting therapy?
Personally, I have used both agents and I feel that this is definitely it is much more widely used and more experience and so we have more confidence.
Dr. Vishal, how we should treat the chronic rejection?
Well, I think that's a very difficult question. And the whole talk was about how to change the outcomes of transplants. So I think one most important thing that we forget as transplant physicians is the next stage of immunosuppression, which decides the infections and the outcome of the allografts. So if somebody has already received immunosuppression prior to transplant, and then depending on that, so that will determine, the basic disease will determine the risk of the outcomes. And optimizing, I would suggest, I have seen a lot of my patients where I've converted the transform study and all the studies where I've converted them from CNI-based regime to mTOR inhibitor-based regimes. In optimizing the immunosuppression, I could minimize my CNIs, so would reduce CNI toxicity in long term. And tacrolimus being more potent than cyclosporin, I guess we should use, we should start taking our immunosuppression because what happens, as we all know, the lesser the rejection, the more the cancer. That what Dr. Jeremy Chapman is talking about right now. I mean, we all know that when we try to reduce rejections, we end up having more cancers and more infections. So optimizing your immunosuppression, sometimes it's more of an art than a science. And I think you have to tailor-make your patient. So there is no blanket answer that I can give to you. But I would suggest you have to look at the basic profile of the patient, who's the donor, what kind of induction you have given, and accordingly, you have to treat your patient. So I'm sorry, I cannot give you a very blank answer on that. But I think you have to individualize. I mean, that's what I say in all the forums. You have to tailor-make induction and therapies for each patient. Because each patient will behave differently. So according to who the donor is, what kind of match we have, what kind of prior infections he has had, what was his basic disease. Depending on that, your immunosuppression during transplant and after transplant will lead to the outcome of the transplant.
Yeah, Dr. Subho, how we should do immune monitoring before and after transplant?
So I guess the immune monitoring before the transplant is pretty straightforward and has been quite streamlined right now. So I think it would suffice to do say a CDC cross match, a flow cross match, and a single antigen screen. So that is our protocol at IKDS. And if that turns out to be positive, we go on to do a single antigen field and do a screen. And subsequently, we will go for the transplant according to that risk profile. When it comes to the post-transplant monitoring, that is a bit tricky. And I mean, there are certain logistic issues like cost, the availability of the tests and everything. So what we typically follow is, I mean, we all know that following the creatinine is a little lay and it doesn't always provide the correct answers. So there are recommendations to do the donor-specific antibody to repeat the assays, but the protocols are very prohibitive. So I think, I mean, we can draw somewhere in between, like say 3 to 6 months, we can repeat, that would be fine. The guidelines say to repeat on 3rd, 6th, 12th, and then maybe on a yearly basis to see the details guideline. And then there are now other tests that are coming up, like the true graph, which is going to be a microarray-based RNA assay, which might give you some insight into what the immune status is. And then, I mean, the simpler things like looking at the macro levels, looking at the BKV status. I find that a very useful surrogate to look at the BKV status and then maybe do some tinkering with the production.
I will ask Dr. Chapman, sir. Sir, in case of chronic rejection, for example, many times creatinine goes above 5 and patient is on triple immunosuppressive regimen of CNI, MMF, and steroid. What you will suggest about when the CNI should be minimized or withhold in case of chronic rejection with creatinine above 5?
So I'm going to answer a different question first, which will help. If you want to treat chronic rejection, you treat it in the first 3 months by preventing. We showed 20 years ago that if you reach 90 days without a rejection episode and with a clean biopsy, in other words, no inflammation on biopsy at 90 days, then your chance of having a functioning graft at 20 years was about 90%. So if you want to treat chronic rejection, you make sure you concentrate on the first 3 months, then you get that right. Because in the patients that you're able to get it right in, their results are going to be good as long as they don't stop drugs. What you asked about is when you're getting to the end game, when to stop. There are no randomized controlled trials for what to do. We've got a paper in the journal which looks at the pros and cons of maintaining immunosuppression to go on to dialysis versus not. Personally, I have always removed immunosuppression and removed the graft, unless it's just with another fibrous tissue, which they usually want. So removing a long-term graft, it's not working, and taking them off immunosuppression. The second comment I make is I don't try and rescue a long-term graft that's failing. What you're going to do is you're going to use drugs in a vain and unsuccessful attempt to rescue a graft that's already gone and that actually started going 2 years ago. And use the drugs that you want to use on the next transplant. And you will now have a much more difficult patient to treat. You want to go around second time with ATG and 3 months later with the next transplant? No. You're much better cutting your losses and going for the next transplant using a high risk regimen then, and not desperately trying to rescue the graft at the last moment. So a lesson I learned very hard in the 1990s, trying to rescue grafts that had gone is a forlorn attempt to either kill the patient or you make them untransplantable second time around. Neither of those are good answers.
Yes. Is there any other comment from the panel?
I think once you have late rejections, it is very difficult. You don't know when it started, and there's a lot of fibrosis and resistance to treatment. So both kinds of infection we are seeing when you start treating some patients, and the outcome will be not good. You recommend again within the following of PSO transplant yearly? You don't do it.
Yeah, we don't do it either. I suppose in well, let me rephrase that. We do for clinical studies. And it's helpful in clinical studies to identify the development of DSA and look at the impact. And so for clinical studies, yes. And I think if you're studying a long-term immunosuppressive strategy, then it seems to clinical impact, because if one strategy for clinical practice, no. And the problem is you don't have really what to do with it. And this is about we do protocol biopsies. So we'll do a 90-day and a 1-year protocol biopsy. So we will spot damage to the graft and inflammation in the graft rather than the end outcome, which is the development of donor-specific antibody.
So when you do a biopsy at 90 days, if there is an inflammation and you're treated, whether the biopsy should be repeated to see that the inflammation is reduced after the therapy, or we have to wait because the creatinine may not be high. It's a protocol biopsy. So whether we need to repeat the biopsy at what intervals?
So if you treated, sorry, if you've done a protocol biopsy, you've got I1, T2, I2, T1, I2, T2, or worse, or even a B1, then we treat it. Because we can't use the creatinine to monitor whether we were successful, which is what you would routinely do with an acute rejection. So you have to rebiopsy. So we'll rebiopsy at about a month, because it's the only way you can tell whether you've been successful. When you've got an acute rejection with a creatinine rising, the thing I don't understand is why the creatinine rises so sensitively, but you can at least monitor whether you've had a response by the drop in creatinine. But if you haven't got a creatinine to worry about to monitor by, we need to rebiopsy. And that's also in one of those papers I've shown.
I have a question. Yes, please.
This question is for Professor Chapman. If a patient is going for a secondary transplant, do you believe that removing the first graft helps in preventing antibody-mediated rejection of the second graft?
So what you observe if you take a kidney out is you actually sometimes get a rebound of antibody. Now the explanation that seems to be most likely, but not probably, is that the antibody is binding into the graft. And so the graft acts as a sort of sink for antibody, and so you can't see it circulating. So when you take the graft out, you now do see the antibody circulating. That immune response was there. That's of course the trouble. You just couldn't see the antibody. And I showed you the Phil Halloran paper, which showed you you're getting graft damage immunologically using his molecular microscope. You can see it, but you can't see the antibody. The antibody is found. So those two facts come together. No antibody, but clear evidence of the immune response damage in the Phil Halloran paper, and a rebound of circulating antibody once you take grafts out in a proportion. Maybe a third of patients get more antibody. And yeah, absolutely. Look at those antibodies when they come up. And I do not repeat the antigen mismatch of a graft that's been acutely rejected, or that's appeared with donor-specific antibodies in chronic rejection. So I won't repeat that antigen mismatch. Of course, in families that sometimes matters, because you're sometimes presenting the same type again and expecting a different answer, which I think is not wise.
Thank you, sir. I would like to sum up the session. Yes, Dr. Shans.
I have only to Dr. Chapman. The leading legend in field of transplantation, and it is a great moment to hear him face to face, and for that we are thankful to be iconic and in task. I have small query, sir. Is there a role of tocilizumab in chronic active ADMR?
It's under clinical trial at the present time. I specifically cannot say anything about it because I chair the data safety monitoring board.
Thank you, sir. To sum up, we can say that single center studies are available on kidney transplant outcome in India. But however, there is no national transplant registry and outcome in India. Till that time, we can follow the KDIGO guideline of using non-depleting therapy like basiliximab in living-related transplant and low-risk transplant,
and using depleting therapy, that is thymoglobulin, in high-risk transplant like deceased donor transplant. Thank you, all the speakers and faculty. I conclude this session and request panelists to join for the photo session.
So we would request you to do the honors as well. Mr. Chairman, once again, sir, thank you. Thank you, Dr. Hegde as well. Thank you, sir. Thank you, Dr. Vishwanath. Thank you very much. Thank you, Dr. Sood, ma'am. Thank you very much. Once again, yes, you've come once again. Thank you, Dr. Thank you, Dr. Banerjee. Thank you. Please.
The next session is on denosumab in post-transplant bone disease. I request Dr. Subho Banerjee, Associate Professor Nephrology at IKDRC Ahmedabad, to moderate this session. Dr. Subho, please.
So, thank you to the organizers for giving me this opportunity. And we have to swing back from transplant to kidney disease again. And for the next talk, it's on denosumab, the role in glucocorticoid induced osteoporosis. It's a major deterrent and a major problem with our transplant population as well as the general nephrology population who are exposed to steroids. I invite Dr. Om Lakhani, consultant endocrinologist in Zydus Hospital, Ahmedabad, to deliver his talk. Dr. Om Lakhani, sir.
So, good evening, everyone. And, I think I'm an odd one out today amongst the nephrologists. So, well, I didn't want to spoil the mood for, the transplant. So, I tweaked my topic to post-transplant osteoporosis, which I think is, more aligned with the theme which we're discussing today. So, in the next few minutes, I'm going to talk to you about post-transplant osteoporosis. And this is the outline of the talk. So we'll, of course, discuss mainly glucocorticoid-induced osteoporosis because, glucocorticoid is often the main culprit. We'll, of course, have a special reference to post-renal transplant patients. We'll stick to 15 key facts about this condition. I'll talk to you a lot about practical tips, something you can implement in your practice from tomorrow itself. And of course, we'll have a special emphasis on the role of denosumab in this entire process. So the first fact, and if you look at the data, the fact is that post-transplant osteoporosis is very common. And I think it's extremely understudied, underappreciated condition. Often this is a condition which, at least in the initial periods of, post-transplant, this is the one which leads to mainly morbidity rather than mortality, or rather than, maybe a hospital admission, hopefully not. But that's what often goes under the radar, right? But on a long run, it contributes to both the mortality as well as morbidity. And that is something which is extremely important. And, if you see purely in terms of number, overall lung transplant patients have the highest risk of developing post-transplant osteoporosis, but The second comes renal transplant, right? So up to 50% of patients post kidney transplant develop osteoporosis, which is a huge number. 50% of your patients develop osteoporosis. And interestingly, most of the damage occurs within the first year post-transplant, right? So there's a rapid decline in the bone function, bone mass within the first year post-transplant. In fact, they've compared this to post-menopausal women and even women who have undergone hysterectomy with oophorectomy, surgical menopause women. And the decline of the bone function in a post-transplant patient is faster, even compared to even a patient who has undergone a surgical menopause, right? So it's such a rapid decline which happens. And remember, these are people of different age groups. These are not necessarily elderly. They are younger population who might be, more active in their lives, and to subject them to, a situation where they're vulnerable to fracture is something which is extremely significantly important. And again, at the end of the day, fracture is what we're really worried about. And 22% of patients after a renal transplant experience fracture within the first year of the transplant, right? Now, when I say fractures, there are ones which are very obvious, right? So they'll have, let's say, a fracture like femur, which requires an admission, or an ankle fracture, which requires an admission. But then there are more subtle ones, like your vertebral fractures, which often goes unnoticed, right? So they are often, patients complain about back pain, and who doesn't have back pain, right? We often miss this out in our clinical practice as well. So if you take the journey of a patient as far as osteoporosis is concerned, there are 4 phases of the patient's life as far as post-transplant osteoporosis is concerned. Phase 1 often starts before the transplant. This is what makes the entire picture more complicated than what it is really. So the patient comes with a baseline CKD and NPD. Then, of course, the patient undergoes transplant, and post-transplant, there's the impact of immunosuppressants. Then, of course, there's a period of time where things get better, right? So there's a re-establishment of the bone microarchitecture. We often try to go to a steroid-free regime, and today I learned, that steroid-free regimes are not as common as we think, right? So, that's what we try to do. And eventually, the patient does regain some of the bone function, but then there's a re-emergence of the original disease, which will require the transplant. The diabetes comes back, the age catches up with the patient, and often that we might have graft failure and so on. So there's re-emergence of the bone disease, leading to the patient again deteriorating as far as the bone is concerned. So the major culprit often are glucocorticoids, right? And glucocorticoids are, I think there's nothing more toxic to the bone than glucocorticoids, to be very honest with you, right? And of course, we all see. You are the people who see the maximum number of patients on glucocorticoids for a long duration of time. But then in community also, glucocorticoid use is very common, especially every single day. And this is very sad, but every single day we see one patient of iatrogenic Cushing syndrome, right? Whether the patient knows about it, whether the doctor know about it, we don't know. But then there's one patient of glucocorticoid induced or exogenous, right? And if you just talk to your orthopedic surgeon who have operated patients with Cushing syndrome or operated patients on glucocorticoids, right? The bone is, completely different from what they're generally used to, right? It's a big problem. So, the interesting thing is that the glucocorticoids impact the bone in many different ways. It, of course, impacts the calcium metabolism. So it reduces the calcium reabsorption from the kidney and from the intestine. It has a direct impact on the bone cells as well. So it enhances the osteoblast apoptosis and reduces the OPG, increasing the osteoclast activity. And there's an interesting, turn of events here. I'll just come to that in the next slide. It also does suppress other hormones, right? So it can lead to, hypogonadism. So your patients will be, estrogen or testosterone deficient, and will impact the growth hormone, GH, IGF-1 axis also, which can, of course, reduce bone formation. So the glucocorticoids have a very interesting impact on the bone, especially, and this is very important for your post-transplant patients. So the early phase of using glucocorticoids, the patient often tend to have basically the impact is mainly on the osteoclastic activity. So it enhances the osteoclastic activity. So initially you tend to have you see glucocorticoids initially long period of time, it inhibits the osteoblast. And that leads to a low bone turnover kind of situation over a long period of time. So glucocorticoids in themselves have a dualistic impact on the bone. And it depends on how long the patient was on glucocorticoids and what's the situation you are seeing the patient. That is what often impacts, how the patient behaves as far as the bone is concerned. But at the end of the day, most of the impact really comes from trabecular bone. Right? The impact is mainly on the trabecular bone. Remember, and we all learn anatomy, right? I think it's the first earliest thing we learn in our MBBS is the bone structure, right? And you have the cortical bone and the trabecular bone, and your spine is the place where you have maximum amount of trabecular bone. Your femur has, right? So glucocorticoids, remember, it has a huge impact on the trabecular bone. And hence it often leads to vertebral fractures, right? So that's the most important clinical impact. So if you have a patient on glucocorticoids, the type of fracture you are expecting is a vertebral fracture. Often, remember, vertebral fractures can be asymptomatic or minimally symptomatic. Like I said, patients will often say, I have back pain. And then we often say, who doesn't, right? I also have back pain, right? So that really does not often translate to, a clinical outcome. So it's very important to screen this patient with a simple lateral X-rays of the spine. Let me tell you. And object did not go to the gym, right? All it did was sit in a vehicle where there was on a journey, and just the bad roads led to the vertebral fracture, right? That's that bad, right? So don't underestimate vertebral fractures. And now, of course, you have DEXA machines equipped with VFA, which is vertebral fracture assessment. So if you have that available, that's a very useful thing to do it, because along with your DEXA scan, you're also screening your patient for vertebral fractures, which is, I think, very important as far as clinical decision making is concerned. So, I think we all talked about steroid-free regimes and a lot of other interesting immunosuppressive things today, right? But earlier it was thought that inhibitors probably spare the bone, right? Do not impact the bone, might have a positive impact on the bone. But unfortunately, that's not true, right? In fact, calcineurin inhibitors themselves contribute to osteoporosis. So it's equally bad. Interesting thing is, we really don't know why and how it does it, right? So there's one theory, of course, is that probably it is, through hypomagnesemia, which stimulates PTH formation, leading to secondary hypopara, leading to more bone resorption and probably osteoporosis. Now, again, contrary to what was earlier thought, it was thought that probably calcineurin inhibitors inhibit both osteoclast and osteoblasts and should lead to low turnover bone disease. On the contrary, what it really does is it actually produces a high turnover bone disease. And this theory of leading to secondary hyperpara is probably true. And that is how calcineurin inhibitors often lead to osteoporosis. So remember, if your patient is on calcineurin inhibitors, not on glucocorticoids, still the patient is equally vulnerable to development of osteoporosis. So how should you screen? And that's the practical idea, right? What should you do to screen your patients, right? So I think it's very important. And I think, I've seen this happen in our hospital, at least. Pre-transplant, all patients should undergo a DEXA scan to document what was the situation pre-transplant. It's very, very important, both from a patient's perspective, medical perspective, as well as medical legal perspective as well, to really document. What should be a DEXA scan should be part of your pre-transplant for sure. But then post-transplant, remember, the maximum deterioration of bone happens within the first year post-transplant. So it's a very good idea to have a checkpoint early on. And 3 months is an ideal time to do a DEXA scan after the transplant. So it's a good point of time. Remember, your patient will be there for follow-up. So do a DEXA. If the patient already has osteoporosis, you treat it and repeat the DEXA annually. But if the patient does not have osteoporosis, then perhaps you can continue screening this patient every 1 to 2 years. How do you diagnose osteoporosis? Again, I'm sure this elite crowd does not require this slide, but just to reiterate the fact, remember, osteoporosis is a statistic. Just like we say, right? So this, when you say a person has osteoporosis, it is defined based on a T-score. And what is a T-score? T-score is when you compare somebody's bone to that of a young person around generally age of 25 of the same gender, right? Now you'd ask me, why would you want to compare say 65-year-old with a 25-year-old, right? Naturally, 65-year-old is going to be having a weaker bone compared to 25-year-old. Well, the point is that gravity is same for everyone, right? Whether you're 65, gravity does not spare you, right? If you're going to fall, right, from a standing height, well, it really does not matter whether your bones, whether you're 65 or 25, right? So what you need to do is you need to compare it with the best possible standard, and that's why you use a T-score to compare. And remember, anybody with T-score less than -2.5 at any site, right? So remember, we often do 3 sites next up, right? So you often do a vertebra, the spine, you often do the femur, and you do the radius, and whichever area is the weakest, that's what you need to consider, right? So again, gravity is same for every part of your body, right? So osteoporosis less than -2.5 at any of these sites will be definition for osteoporosis. There are times when we use a Z-score, right? So Z-score is when you're trying to, generally use it for younger people, when you have to compare the person, with somebody who is of the same age and gender, right? So you're comparing a 40-year-old male, you use a Z-score, you compare with another 40-year-old male to see the difference, right? And a low bone mass defined on a Z-score is less than -2.0, right? So if my bone, I'm 38, right? If a peer of mine is 38 and is, bone BMD is XYZ, and mine is less than -2.0 of that, I am having low bone mass, and I'm the person who needs to be treated. Okay, fact 9, right? And this is something important. A lot of things are, we still trying to understand this. And there's an important role played by post-transplant hyperparathyroidism, right? In fact, this is probably a differentiating factor. Now, there are 2 issues. One, studies have shown that it impacts the graft as well. So again, post-transplant hyperparathyroidism is associated, whether it's a cause or effect, we don't know, but it's still associated with reduced graft survival. But of course, it also is associated with osteoporosis in these patients. And remember, you could have a secondary hyperpara, where of course the calcium would often be low or normal, but you could also have primary hyperpara in some of these patients where calcium could be elevated. And of course, this is something, your post-transplant hyperparathyroidism needs to be given priority in terms of treatment, recognizing the disease. Post-transplant is a good idea to do an extra scan to screen these patients. Lifestyle measures are very important. Remember, this is a place where, a little bit of aerobic tools. That's of course your outcome for the transplant is concerned. And the third and perhaps a very important step is to subtype the bone disease, right? So whether you're dealing with a high turnover bone disease or a low turnover bone disease. Now, CKD, MPD, the entire disease, entire understanding of the disease is the backbone of that is really high turnover versus low turnover, right? that's important. But unfortunately, this does not leave you even after the transplant, right? That same problem continues even in post-transplant patient. And it is now complicated by the fact that you're giving, medications which can also impact this situation, right? So it's very important to subtype and classify this bone disease. It was probably not important 20 years back to do this, but it's important now because you have different treatments available for different subtype of bone disease, right? So if you're dealing with a high turnover bone disease, you probably use anti-resorptives, whereas if you have low turnover bone disease, that is where you consider using a teriparatide, right? So that is where the treatment would also differ. So how do you subtype a bone disease in a post-transplant or for that matter, a pre-transplant patient? So it's high turnover versus low turnover. Now, obviously, the gold standard remains bone biopsy, right? But not any of us really do it. There are practical issues with doing a bone biopsy. More importantly, there's lack of expertise in terms of, reporting bone biopsies. And that's one of the biggest challenges as far as bone biopsy is concerned. But thankfully, we have good biochemical markers which are substitutes to bone biopsy. And again, studies have shown that they correctly identify the subtype in about 88% of cases, right? So you can actually use biochemical markers in place of your bone biopsy to always correctly classify your patients as far as the bone diseases, subtype of bone disease is concerned. Again, I'll not go through too many bone markers. There are just two. See, bone turnover markers is a science in itself, right? It's a science which a lot of endocrinologists have still not been able to understand itself, right? So it's a complicated disease. There are a lot of challenges with use of BTMs. But as far as nephrology is concerned, or as far as endonephrology is concerned, there is two which you really need to know. One is, of course, your parathyroid, your PTH, and second is your bone-specific alkaline phosphatase, right? Bone-specific alkaline phosphatase is now easily available from a lot of labs, including labs in Ahmedabad. So it's a test which is not that expensive for that matter. So it's something you can perform, order, right? And a PTH typically less than 79, and a bone-specific alkaline phosphatase less than 12.9 microgram per liter is almost certainly diagnostic of a low turnover bone disease, right? So this is where, and this is why you should recognize a low turnover bone disease, because this is a place where your anti-resorptives are contraindicated, right? So that's something you need to really understand and appreciate. So, like I said, how do you manage, right? So we are moving to a world of precision medicine, and now your management should be based on the turnover. So if you're dealing with a low turnover disease, that type of patient of yours will be a good candidate for teriparatide therapy, right? Whereas if you're dealing with a high turnover bone disease, then you should consider giving your patient denosumab or bisphosphonates or anti-resorptive therapies, which become a better choice in these patients. Now, again, within the first year post-transplant, most likely you will be dealing with a high turnover situation rather than a low turnover situation, right? Because of multiple factors. So, first year post-transplant, generally your patients would be a good candidates for anti-resorptives rather than giving teriparatide. But of course, your situation may be dictated by other clinical circumstances as well. So let's then distill down to anti-resorptive. So let's say you have a patient post-transplant, you've done an exascan 3 months post-transplant, you found that the patient is osteoporosis. You found that the patient has a high turnover bone disease, right? Patient is already on glucocorticoids. What should you give? Should you give this patient a denosumab or should you give this patient a bisphosphonate, right? Now, when you have a clinical query where you want to answer it, the best answer really comes from your meta-analysis. And this very specific question, I found one very specific meta-analysis to answer this, which was published in 2019, where they compared denosumab versus bisphosphonate, not in every Tom, Dick, and Harry patient, but specifically for patients on glucocorticoid-induced osteoporosis. So they compared denosumab versus bisphosphonate in glucocorticoid-induced osteoporosis. There are 3 large studies which are included, and these studies, this meta-analysis conclusively proved that denosumab significantly increases lumbar spine and hip PMD compared to bisphosphonate. So it is clearly superior in terms of its effect on the bone as far as the glucocorticoid-induced osteoporosis is concerned, right? I think in 2000, after this meta-analysis in 2019 or so, US FDA gave approval for denosumab for the specific indication of glucocorticoid-induced osteoporosis. So it's an approved drug for this specific indication. So let's talk a little about denosumab, right? Now, interestingly, right, which is perhaps where we use denosumab probably more in a hospital setting than even osteoporosis, and that is hypercalcemia, and that is something which connects again endocrinologists and nephrologists, right? So, for hypercalcemia, irrespective of the etiology, right, irrespective of the renal function, denosumab works wonders. Right? Ideally, of course, original dose was 120 milligram. 120 milligram is slightly costlier. So, we started using 60 milligram as well. Post in hypercalcemia patients, right? And 60 milligram also works beautifully, right? So it works including patients with primary hyperparathyroidism, or if you have a patient with vitamin D toxicity, if you have a patient with, all these conditions, it does work beautifully, right? So it's a very useful drug to use in patients with hypercalcemia. Also, very interestingly, we had several patients over the years. So in the last 6 years, I would say perhaps about 10 patients having documented primary hyperparathyroidism. But for some reason, the surgery could not be performed. Either the patient refused surgery, or the patient, was not fit for surgical intervention, or you could not localize the parathyroid gland, or the patient already underwent surgery, but there's a failed surgery. Right, in a lot of these patients, we started considering medical management of primary hyperparathyroidism, where we give a combination of cinacalcet with denosumab, and eventually pull away cinacalcet, just maintain the patient on denosumab over a period of time. And these patients are doing very well, right? The bones are fine, no fractures, no renal calculi. They're doing very well as far as the long-term outcome is concerned. And recently, this approach, which is now considered medical management of primary hyperparathyroidism, has found approval in the primary hyperparathyroidism guidelines as well, where they're now accepted medical management as also a potential form of treatment in those patients where surgery. Obviously, surgery remains, if you can localize the adenoma and the patient is fit for surgery, that would be an ideal treatment. But in those patients, for some reason, if you cannot operate, medical management also has both in short-term as well as long-term outcomes found to be pretty satisfactory and non-inferior to a surgical outcome. So I think perhaps in future, we will probably that's the answer. So but it's a safe drug. Persist in a bone, right? So you have some factors which stimulates bone, which leads to activity of osteoblast. And this osteoblast release rank ligand, which act on the rank, which is there on osteoclast, activates the osteoclast, which leads to bone breakdown. This further stimulates bone formation. So it's a cycle. Now, this is the natural cycle, right? The cycle of life and death. But what we want is the patient already has osteoporosis. And remember, it's a high turnover osteoporosis. So we have a cycle which is more rapidly moving. So what you want to do is you want to dissociate the bone formation from bone breakdown. So you don't want the bone to break, but you want the bone to form, right? And that is where you use something like a denosumab. So what denosumab does is it's an antibody against the rank ligand. It binds against the rank ligand and prevents it from binding with the rank. So prevents the osteoblast from activating the osteoclast. So osteoblast process continues, the bone formation process continues, but it gets dissociated from bone breakdown. So this bone breakdown does not happen, and that leads to we are taking this as an advantage for formation of the bone. So this is how denosumab really acts, and this is where it is useful in patients with osteoporosis. Right? So I end my talk here, and thank you for patient listening. Thank you.
Thank you for this very lucid and very detailed presentation. So I request you to please stay back for the panel discussion. So for the next part of the the program, we have a panel discussion, and for that I'd like to invite the panelists, Dr. Manish Jain from Kolkata. He's a nephrologist. Dr. Anil Kumar He's a nephrologist from Apollo Bangalore. Please, sir. Dr. Medanti Rajiv is a nephrologist from Hyderabad. Dr. S.J. Acharya, sir, from Nagpur. Dr. Nageshwar Reddy, sir, from Hyderabad again. And Dr. Tarun Mittal from Agra, UP. Panelists. Dr. Manish Jain, sir, experience about the sensitization of the community, less sensitized, and like what is your take on that?
Good evening. So basically, when we are treating a CKD patient, we are more concerned with CKD MPD rather than osteoporosis. Because we are tried with the calcium phosphate damage and the other related. Because of that, we are generally avoid evaluation from the osteoporosis. In the most of CKD patients, generally we see a bone disease or dystrophic, not in the osteoporosis.
So is there overlap in the patient profile and like what you see?
I will say the patient more than 50 years of age and even patient with postmenopausal period is developed for the osteoporosis.
So, Anil Kumar sir, like how frequently do you assess your patients for osteoporosis, particularly say stage 4, 5? How common is that?
Osteoporosis. Now, with the osteoporosis incidence of almost 30%. So, CKD, the KD guidance 2017, they have suggested recommended that BMD assessment of osteoporosis by doing the regular assessment of BMD. But how frequently we need to monitor was not commented because there were some discrepancies. But at least annual monitoring of the BMD mathematics is useful in probably treating these patients with osteoporosis.
So is that something you're doing as a routine, or is there a typical triggering factor which will lead you to request such a test?
Especially with the risk factors of osteoporosis, I think it is worthwhile doing it for all patients.
Okay. Dr. Rajiv sir, what are the limitations of bisphosphonate therapies in CKD patients, for example?
Yeah, that's a very good question. And I think the answer is kind of evolving over the last few years. Earlier, we had this kind of blanket recommendation that you can't use bisphosphonates below GFR of 30. And of course, the reasons are well known. Historically, bisphosphonates used to cause renal failure, especially experience with IV pharmacology and all that. And of course, these are drugs which are renally excreted. But what we now find is that, especially when it comes to below GFR of less than 30, we are slowly tiptoeing back into bisphosphonates. So now evidence says that oral bisphosphonates, especially used at after dose, at longer dose intervals. It is effective in patients with proven fragility fractures. But we still don't, as such, treat osteoporosis. I mean, our focus is not treating osteoporosis per se in somebody with GFR less than 30. We are focused on the middle bone disease aspect of it. But we are slowly going back. So it is challenging. There have been studies which looked at patients, the usage of bisphosphonates in this particular group, and you find that yes, creatinine rises, but it's not so much more than in somebody with the GFR of more than 30. So I would say the answer is kind of evolving. It is challenging.
So is there a particular molecule which you are more comfortable with using?
To be frank, I mean, I've used oral bisphosphonates. So something like Cedronate. IV we've gotten away with a few patients at a very low dose. But my experience is not that great.
Thank you, sir. Dr. Nageshwar, Dr. Acharya, sir, like, when would you start treatment for osteoporosis in CKD patients?
From the beginning of the diagnosis of CKD, we search for whether the person has got symptoms like bony pains, whether he is developing any fractures, whether the person has got acidosis. For example, a child who has got viscoelastic refractory metabolic acidosis and lack of growth. So all of them are actually suffering from osteoporosis. So better to go ahead with the serum calcium level, vitamin D3 level, the parathormone level, alkaline phosphatase bone specific, and preemptively try to find out that who has got osteoporosis and treat them accordingly. So don't wait for the fractures to occur. Preemptively try to find out the osteoporosis. And with this, I found that many of the children who are not growing and they have got severe metabolic acidosis, though clinical the creatinine level is normal, but their growth pattern is less, and they benefit from the vitamin D therapy and calcium therapy and the metabolic control the metabolic acidosis. Those patients who are CKD not on dialysis, CKD stage 3, stage 4, we should do their bone density. And if it is suggestive of osteoporosis, then we get recently. Those patients who are on dialysis, of course, to at the earliest opportunity to bone density and treat them accordingly. Post transplant, of course, CSA, steroid induced osteoporosis, that is to be treated as per the findings of the bone density.
Thank you, sir. So, Dr. Nageshwar, sir, like, where do you place denosumab in current day practice of CKD associated osteoporosis?
Yes, previously, Dr. Raji was told in CKD patients, our management team now was with CKD MVD management. After the 2017 guidelines, seeing osteoporosis after correcting CKD, if there is osteoporosis, after correcting CKD MVD and defining it as a high turnover or low turnover disease, if there is osteoporosis and high turnover, to go for anti-resorptive therapies. If there is CKD, MVD, and osteoporosis and low turnover, go for the anabolic drugs. So, in CKD till 3, in the anti-resorptive therapies, anything can be used, denosumab or the alendronate racemate drugs. Coming to CKD 4 and CKD 5, not on dialysis, as the previous speaker has said, panelist has said that there should be some caution with using these drugs, anti-resorptive, especially the bisphosphonates, as the newer molecules are coming like denosumab, which are more safer to use than compared to the, and except for the cost. So I think denosumab has a role in CKD 3, 4 patients, also in the post-renal transplant patients, where again there is the chances of proteinuria, exaggerated loss of GFR in the post-renal transplant setting. So when you see a high turnover bone disease, go for probably denosumab. If it is a low turnover disease, then teriparatide is a drug of choice.
Thank you, sir. And Tarun, sir, what is the frequency of assessment in post-transplant patients? Like, how often do you actually look for osteoporosis, given the lot of burden of medicines and the costs related to transplantation?
So, as was discussed in the presentation, 3 months would be a good time to do a first assessment, initial. And then if you are osteoporosis and you're starting treatment, then maybe you can get a BMG test annually. And if you not find significant osteoporosis, then maybe do a 2-yearly assessment would be that. So, just one comment on the last question. So, with denosumab, it can be used in CKD 4 or 5, but some things are to be remembered that once you initiate a patient on denosumab,
it is very important that it should be continued for a long time, because if you stop denosumab, like if you recommend 6 monthly administration, once you stop denosumab, there is very rapid bone loss, and so it has to be followed. If a person say in India, in Indian setting, you start a patient getting 4 or 5 on denosumab. Now this person is probably not a candidate for this hospital, and we stop denosumab, and what you are going to end up with is a lot of more bone loss and more vertebral fracture. So it is very important to discuss this thing with the patient upfront, that if he is initiating a person on denosumab, he should be able to continue this long term. That is one thing. The other thing is, and which I myself find a little confusing, is how to differentiate CKD MVD from osteoporosis. So CKD MVD is an entity which is a little different from the routine garden variety post-menopausal osteoporosis or corticoid use osteoporosis, and has a slightly different management altogether. So if a person, say the young person who comes with hyperparathyroidism, advanced CKD, he has high PPH values and all and the routine this thing, and you get a bone scan, sorry, a DEXA scan, and he has evidence of osteoporosis. So this low PMT would be simply because of the CKD MVD itself. So now this person, so traditionally we treat such patients with active vitamin D, cinnac acid, etc. So is this person going to respond to anti-resorptive therapy or not? As because these therapies have been traditionally being studied in the classical post-menopausal and glucocorticoid-induced osteoporosis. This is something which I would like to learn from you, sir.
Yeah, it's a good point. So the point is, it's like saying that if a patient comes to me with hypertension, whether it is because of the CKD, or whether it's essential hypertension, whether you are dealing with a secondary cause, or third cause of hypertension. End of the day, what you see is that the patient is very hypertension, right? So you will consider, giving insulin. Also, anti-hypertensive therapy would depend on what the underlying cause is, right? So you can, or maybe some other comorbid situations. So technically, osteoporosis is, like I said, it's a statistical factor. So any patient, whether the patient has CKD, MVD, whether the patient has osteomalacia, whether the patient has severe vitamin D deficiency, or whether the patient is everything is fine, the patient is elderly. When you do a DEXA scan, if it's less than -2.5, the patient will be labeled as just like a patient with blood pressure of more than 140, it will be labeled as. So that's where the definition means. So a CKD MVD with a BMD less than -2.5 is still osteoporosis. Right? Now the point is that whether it's a primary osteoporosis, which is age, or whether you're dealing with a secondary situation, whether it is likely related to the situation in this situation, or maybe some patients with primary hypoparathyroidism, some other reasons, maybe malaria and so on, maybe drug abuse. So, it's whether it's primary or secondary. Well, at that point of time, you need a smartphone. Right? What matters is, what kind of therapy you offer that patient. That choice of therapy is more dependent on the turnover rather than it is dependent on the etiology, right? Because that is where at the end of the day, what type of turnover you have depends, that will ultimately translate to what kind of medication. Either case it will be right. So if you're going to give the right drug to the patient with the right turnover, then it will protect whether that is primary or secondary or mixed. So at the end of the day, I would say that you really don't need to differentiate whether it's a primary osteoporosis or secondary CKD, which I'm sure it is going to be, and in fact, very interesting because you're all vitamin D deficient, right? There are studies done in India where you had patients with severe vitamin D deficiency, where you had done an DEXA scan initially, and then you replace the vitamin D, repeat the DEXA scan. There's a significant improvement in DEXA even without giving any details of it. The point is that all this data is basically generated from a large patient population, even including Indian data, people of vitamin D sufficient who do not have CKD, who do not have any other bone disease, who are all normal, right? You're comparing them to somebody who is a disease population, right? Which is again a complexity in itself. So I think you need to take the input of DEXA instead of taking it as a gold standard. It's part of your other clinical diagnosis, and especially for complex situations like a CKD, you need to take all the parameters. I think let's not try to differentiate that. The point is you take all this one input from the other inputs like your calcium levels, your vitamin D levels, your CKD scale, your other medications, your phosphate levels, everything. Take all these into consideration.
Dr. Okay, any is ma'am. Patients who are CKD 5 who had proven fragility fracture and you put them on this map. When they go for a transplant, how do you manage the osteoporosis treatment post-transplant? Do you continue with Densmar indefinitely, or is there a point at which the healthy metabolic state kind of stops you from doing that? That's something. It's maybe a very basic note. PTH has a very short half-life. Whereas bone turnover and everything this happens over weeks and months. Whereas we make decisions on what is actually happening within the bone based upon the PTH level. So how right are we in terms of interpreting that?
I think both excellent questions, and I'll also address a very important point which Sir said is that the problem with denism, right, which is I think the only flaw I would say major flaw is that unlike bisphosphonate gets incorporated, so continues to protect the patient even after the patient stops it. Whereas denosumab, the day the patient misses the patient is vulnerable, right? It protects till it's given. Once that effect goes away or once the patient misses the drug, protection goes, right? So that's the challenge with denosumab. So your patients on denosumab need to be told that you need to take it every 6 months religiously, right? Otherwise, you'll be as vulnerable as you were, at the beginning of the therapy, right? So that's one important point which is the key point. Coming to your question, so you asked two questions that I think both are very important. So first is you have a patient who is already having osteoporosis, already having fragility fracture, pre-transplant. He or she's already on medicine, and the patient underwent a transplant. I think it's only going to get worse on that point, right? Especially for the first year or two post-transplant, especially when the patient will be on higher dose of immunosuppressive agents, other metabolic factors will come into play. So that patient is most vulnerable at that point. So you will definitely continue with that patient for that patient at that point, right? Now, on a long run, right? Maybe it's a young patient. The underlying CKD improves. The patient is off steroids. The patient's bone has improved, which is unlikely. But if it does happen over a period of time, maybe on a long period of time, everything really you might consider discontinuing. But I think it's a very rare patient that we have. And remember, the problem with osteoporosis is that we are all running against the clock. So aging is happening to everyone. Whether it's a 30-year-old patient who was undergone a transplant, whether a 70-year-old patient who was undergone a transplant. And the most important parameters for both is age, right? So whether you're giving glucocorticoids, whether you're giving anything else, age is something which is constant, right? It is always going to get, right? So a patient who is 70-year-old, after 4 years is 74-year-old. So his or her bone was worse than what it was even, chronologically, right? So that's the challenge where I really doubt whether, there would be a patient doing so well that he or she might get, but this is something which will expect. Most of the patients will require, or for whatever, most of these patients will require continuing the drug for a longer period of time. I think that is what, we should also be addressing. Yeah, regarding the PTH. So the interesting thing about PTH is, unlike other hormones, remember, PTH is under suppressible. That's the difference between PTH and other hormones. And there are a few hormones in the body where they are suppressed and they're not stimulated. Right. So, for example, let's say a testosterone would be stimulated. There are emphasis to stimulate your leading cells to produce it. But the PTH control is exactly the opposite. It is actually under suppressible. Right. So when that suppression goes away, there is more PTH release. When that suppression is there, the PTH is, controlled, right? So though PTH has a short half-life, it is continuously released to the right? Always there. So hence, in that sense, what you are doing is you are looking at how PTH suppression is being impacted by either the disease or by medication or by some other factors, right? But the PTH release is constantly being there. Right? So even though PTH may have a short half-life, right? Or for that matter, point is that it is still a very useful test for consideration because at the end of the day, it's still there in the body, continues to live, right? only thing is that in suppression levels will change depending. So I hope that. Right.
So any final comments from the, yeah, please, sir.
See, as we all talked about denosumab and bisphosphonate, and they have a longer life. And as he rightly said, Tarun rightly said, you know, we have to repeat it every 6 months, the immune system. So post-transplant initial effects, especially first 3 to 6 months, where there are a lot of factors interplay. When you are dealing with graft stabilization, you are dealing with the bone metabolism, everything is coming back, even though that comes in, who are non-diabetic. So when multiple play of factors take place immediately post-transplant, your challenge as a nephrologist is to stabilize the graft first. And during that time, bisphosphonate is would not be the best drug to initiate these patients. As you directly said, I mean, if you're somebody already osteoporotic or somebody you are anticipating on a BME osteoporosis, I think first year would be the time when denosumab would be the drug of choice. And once you have stabilized the graft in 1 year, then you can switch this patient to bisphosphonate because that will be viable. That would be more cost effective, and I think that would be more feasible for the nephrologist to work on it. And that would be my take on that. Thank you.
So barring the cost, I'll tell you, in terms of convenience, so let's keep cost aside, right? Let's keep cost aside. The fact about denosumab, which is, you know, probably why I use a lot in my practice, is actually convenience. It is one of the most convenient drug to administer. I tell you what, it's a subcutaneous injection, right? It has to be taken, unlike IV bisphosphonate, which is an IV, right? Oral bisphosphonate has, you know, its own works in terms of giving. Secondly, in terms of clinically visible patient-related side effects or adverse effects, denosumab probably has none, right? Except for probably hypocalcemia, which will happen with almost any patient. You know, on the contrary, because I was always trained on, you know, giving bisphosphonates, and it's always the resident who, you know, gets the brunt of it, right? It's a very unpleasant drug to give, especially IV bisphosphonate. Patient has fever, it has to be administered in a daycare setup or maybe hospitalized setup, right? Patient often develops fever after the drug, often for multiple days. There are a lot of patients who refuse taking a second shot of zoledronate after they take the first, right? It's often a problem, right? So though technically it sounds, you know, as a simpler alternative, the problem is in terms of practical use, except for the cost. Denosumab is much more convenient, much more easy to administer. You really don't have to worry too much about that. You prescribe it, you forget about it. Only practice, like I said, the patient has to take it every 6 months. That's so in terms of convenience, is a very good drug. Obviously, the benefits are also there in terms of the data also vis-a-vis this. So I think convenience factor is a very strong play. So especially busy nephrologists, you have other things to take care of. I think, you know, denosumab is an easy prescription because you don't have to worry about any other thing. Prescribe it for them. That's the good part. Except of course cost, which you know eventually of course will come out. Because zoledronate, when you know we are getting, it used to be 20,000, used to have the original brand. That was also 20,000. That was also costly. Now we have for generic alternatives, but you know, apart from that, that's you know, this is the convenient. So that worry is there for even bisphosphonates. So that is there. It's ONJ is seen in mainly patients. One, low turnover bone disease, if you administer them, they are likely to develop problems. Even atypical fracture, they might also develop ONJ technically, right? So do not give it to patients with low turnover. That's one thing. Secondly, all these sinister complications occur with longer doses, with longer duration of therapy, with higher doses. Typically seen mainly, so remember, we are giving 60 milligram every 6 months. Our colleagues from oncology give 120 milligram every 3 months. That is where really you expect them to have those complications. In my practice, I've was in my patient, I've seen it in oncology, right? So we do not see that in our practice because we are getting much lower dose compared to the other practice. The only thing is you have to be careful. Do not give it to a patient with a low turnover. Then you are probably inviting them.
Excuse me, can I have a question? Here. I wanted to ask Dr. Lakhani regarding glucocorticoid-induced osteoporosis. Is there any role of prophylactic denosumab, especially those who require a little long-term steroids, not of transplant patient, but pre-transplant nephrotic syndrome patient, as number one. There are a couple of linked questions to this. So any prophylactic role of denosumab in such situation? Second is whether if we have the indication for glucocorticoid is now not there and the patient has been given 1 or 2 injections of denosumab. Can you stop this medication? And if so, what is your recommendation?
Yeah, so both very good questions. So as far as prophylactic, I think I would say technically no, unless you document the patient is in hospital, right? And documentation of osteoporosis would all that you require would be an exam, right? So you would, before you start denosumab, it's a very good idea to do the exam, which is not very expensive also compared to the drug, right? So you do a DEXA scan baseline because you have something to follow up the patient on, and you know at baseline what was the situation, and then you know how to follow it up. What you said in effect is very attractive option. It has already been tried for prevention of osteoporosis. Has already been tried in with this hospital, especially oral risk hospital, where your electrolyte 35 milligrams is basically designed to prevent osteoporosis. Right. So it has been bisphosphonates have been used properly, but denosumab there is absolutely no data for prevention of osteoporosis. You only have data for prevention of fracture in patients with osteoporosis. Right. So we do not have any preventive data. I'm sure eventually you will have a data emerging, right? Because we always try to expand the indication. So eventually you will find a data which will show that you might give it prophylactically for patient not having osteoporosis, what are glucocorticoids, it might have a role. Right now we don't have any data. So I would suggest you probably stick, if you want to give something, give 35 milligram of if patient does not have existing fracture, probably a good idea to give a oral bisphosphonate 35 milligram electrolyte would be a good idea. Right. Regarding your second question, especially if you're for some reason you're discontinuing bisphosphonate, discontinuing denosumab, you have to use something in alternative, right? Whether that alternate includes a bisphosphonate or some other agent, that's your choice, right? But generally, bisphosphonate or maybe some other agent has to be given in place of denosumab. So if you're not giving denosumab, remember denosumab, these are all anti-resorptive drugs, right? That's interesting. They are anti-resorptive, they are not given enough. So they prevent breakdown of the bone, but they do not cause bone fall. Now, teriparatide, something like a teriparatide, even for 2 years and then forget about it, probably don't give it because it has built the bones. But what these drugs are doing is they are preventing the bone from breaking. So if that you're removing that drug, then the prevention goes away. Right? It's like vaccination. Vaccine is a half-life of some, let's say, duration of action for some period of time. Once that effect goes away, the vaccine protection goes away. Right? Same way, denosumab protection goes away once it goes. So then you probably need to give either a bisphosphonate or some other agent in place of that. Otherwise, the patient is left to the vulnerability and the fracture. So that's
So thank you, panelists. In the interest of time, because some of the people here they have lives to carry and everything. So I'd just like to break this up right here. Thank you for this excellent discussion, which seemed to go on forever. Thank you, everybody. So I'd like to invite Dr. Vivek Kote to please felicitate all our other speakers and the panelists with the customary shawl.
Thank you, Dr. Thank you, Dr. Acharya, sir. Thanks again, Dr. Reddy. Thank you, Dr. Reddy. Thank you, Dr. Hani, the star of the show. Thank you. Thank you, Dr. Anil. Thank you very much. Last but not least, thank you, Dr. Manish. After apologies for all the flight that delayed that happened today. But thank you very much for that. Thank you.
And for the end of it, I would like to invite, let us just pose for a photograph, please.
Just one.
I would request Mr. Panak, Sunil Panak, he's a head for our nephrology and urology business, to convey a vote of thanks to the lovely audience that we had and all wonderful speakers and moderators.
Professor Chapman sir to come on stage.
Good evening, ladies and gentlemen. What a wonderful international speakers program it was. Just a little bit of interesting trivia, Professor Chapman, about the state of Gujarat where we are having this program. Gujarat has given many important leaders to India like Sardar Patel, Mahatma Gandhi, and the current Prime Minister, Narendra Modi. But that's not all. Gujarat has been the gateway to international commerce since last 3,500 years. Just a couple of hours drive away is the town of Lothal, one of the most advanced ports of its era. Today also, Gujarat continues its foray in the excellence in nephrology through institutions like IKDRC and many others. So thank you, Professor Jeremy Chapman, for squeezing time out of your busy schedule and agreeing to share your rich experience and wisdom. Thank you, Dr. Vivek Kutte, for providing a platform for this fantastic feast of clinical experience and learnings. Thank you all, the moderators and panelists, for making this program interesting with your insightful interactions. Thank you all delegates for taking time out on the busy Monday evening. Last but not the least, thank you team in DAS for working very hard behind the scenes for making this program successful. Thank you all once again, and I invite all for the dinner. Thank you.
I request all present in the hall to join for the group photo on the stage, please. Request all of you to come on stage.
Doctor Sir. What is the back experience to be black color? एक सेकंड लगे हाँ
Sir, picture तो यहाँ पे आ गया।